Good evening, everyone. Thank you for gathering here today. We have planned mechanical circulatory support symposium by the cardiology and the cardiac surgery teams. We'll get started today in the panel. I'd like to invite Dr. Anuj Kapadia and Dr. Sonali to please come. In the first session, we'll divide this symposium into three sessions. Who needs mechanical circulatory support? Dr. Narasimhan, you can please also join the panel. So the first session, we'll just talk about cardiogenic shock profiles, and then Dr. Rajiv will speak on this, and Dr. Muthaya will talk to us about advanced heart failure in the clinic. So we want to set the stage with who are the people who would benefit from mechanical circulatory support. And then we'll take a break for discussion and move on to the next section. So I'd like to invite Dr. Rajiv to the dais. Thank you.
Good evening, everyone. Thanks, Horace, for the invitation. And let's kickstart this program by looking at the shock profiles. So what I have done in this talk is, as we can understand, I think there are a spectrum of people who will be listening to the talk. Right from physicians to cardiologists to people who are directly involved with mechanical circulatory support. So hopefully everyone will have something at the end of the talk to take back home. We'll just start with a case. It's written as case 1, but there's only one case which we'll be discussing. So this was a 67-year-old male. Patient had an anterior wall MI with a window period of around 8 hours. QRBB with LPHB on ECG with moderate LV dysfunction, and patient was in Phillips class 2, heart rates of around 90 and a blood pressure of around 130/90. This patient, as expected, was taken up for a primary angioplasty. You can see a RCA which is diffusely diseased with lot of dissections, and the culprit lesion was the LAD. Most likely, probably there were a lot of collaterals which were going to the right coronary also. You can see the LAD in the mid segment totally occluded. So this patient had a successful primary angioplasty with a TIMI 3 flow distally. At around 10 p.m. this angioplasty was done somewhere around 9:30 in the night. And around 10 p.m. this patient was shifted to the ICU. His pulse rates were 110. And blood pressure was 170. Now the question which we need to ask ourselves is, what would we do next? Do we just leave the patient like that, continue with the drugs which the patient is getting, and then reassess in the morning, the next day morning? Or is there something else which should worry us in this particular patient, where we try to evaluate further and try to see what exactly happened? So let's come back to our talk and then probably see what happened with this particular patient. So whenever we deal with a patient in shock, there are certain questions which we need to ask ourselves. First, of course, it starts from the fundamental aspect, whether the patient is in shock. If yes, then what is the stage of shock? What are the modifiers likely to influence this outcome in this patient with shock? What is the phenotype of shock? And we look at the clinical variables as well as the hemodynamic variables to identify the phenotype of shock. And finally, how do I manage, which I'll just touch upon because there are other speakers who will be going into the details of how to actually manage that particular type of shock. So just something about shock. This is a lovely statement which was made way back in 1800s, where Dr. John Collins mentioned that shock is a momentary pause in the act of death. So if you don't change that pause into a stop button, probably you will end up in a situation where you lose the patient. What have we achieved till now? If you look at the 2 decades of studies which have been done in shock, it's surprising to note that the mortality has remained quite high even now. So though the Iabp Shock 2 trial has a mortality of around 34%, many other studies still hover around 40%. So from around 50%, we have achieved around 10% reduction to around 40% in the past 20 decades. The reason for that is shock is not just one entity, but it is a multifaceted syndrome. we think it's just a decrease in blood pressure, but it is a combination of multiple factors. There is an issue of inflammation, there is an issue of ischemia, there is an issue about vasoconstriction and volume overload. So multiple factors together reducing the cardiac output, causing a multi-organ dysfunction, and then finally resulting in the death of the patient. So this aspect of acute inflammatory process going on there when the patient has gone into hypertension should be borne in mind. So let's come back to the talk proper again, and let us look at what is the definition of a shock. So don't get perturbed by this slide. These are different definitions which are used, but the common conventional definition which we need to be aware of is a systolic blood pressure of less than 90 or a mean of less than 60, a cardiac index of less than 2.2, a wedge of more than 15, and other hemodynamic considerations. So we need to just spend a minute here and understand that these are important hemodynamic parameters which have come up now, and any understanding of mechanical circulatory support and how we escalate or de-escalate the supports depends upon these parameters. So here we start off with a cardiac power output, which is the cardiac output into the mean arterial pressure divided by 451. Anything less than 0.6 indicates shock, and we would like to keep it above 0.6. A shock index, a very simple index, which is heart rate divided by the systolic blood pressure. If it is more than 1, again indicates that the patient is going into shock. And there are definite parameters for right ventricular shock, the most famous of which is the PAPI, which is the pulmonary artery pulsatility index, where you take the systolic pressure, subtract the diastolic pressure and divide it with by the central venous pressure. And if it is less than 1, it indicates that the patient is in RV failure. CVP, of course, if it's more than 15, and the CVP pulmonary capillary ratio of more than 0.6. So we need to look into all these parameters to make sure that we are not missing a patient who is either in impending shock or is in shock proper. So now let's look at the second question, which we need to, once we have decided that the patient is in shock, the next thing we need to look at is the stage of shock. So this is a recent development coming up somewhere around 2018-2019, which has been revised in 2022 now. The SKY actually came up with a lovely classification of shock, which clarifies the definition, the staging, as well as the management of shock. So it is a simple alphabetical order, A, B, C, D, E. What does it say? A is at risk. The patient has an extensive anterior wall MI, a significant part of the myocardium is lost. The patient might be having good pressures, but the patient might be going into impending shock. So you need to be careful and keep your eyes open to make sure you don't miss a sudden development of shock in that patient. B is the beginning of shock, which is the classical definition of shock. So the pressures have come down. C is the classical shock, where with hypotension, it is associated with hypoperfusion. So once there is hypoperfusion, the indirect indicators of hypoperfusion are the increase in the lactate. So if you have hypotension with the increase in lactate, this is a classic shock. You start treating either by inotropes or by putting a mechanical circulatory device. And in spite of starting those medications, if it's not improving, then it's a deteriorating shock. So it goes into stage D, and E is almost impending arrest, where in spite of multiple inotropes and multiple circulatory devices, the patient is not improving. Now, among all these stages, one of the main modifiers is cardiac arrest. If the patient during any stage had a cardiac arrest, the prognosis in all these stages becomes much worse than what it was to start with. The same definition can be done in a hemodynamic manner. So A is where all the hemodynamic parameters are all right. B is where the hypertension has started, but cardiac index is still all right. That is, hypoperfusion has not started. C is where the cardiac index has come down. So the patient has started hypoperfusing, and all the things which we discussed in the definition of shock now have come into in classic shock. Deteriorating, of course, is dependent upon the inotropes and the amount of mechanical support which we use. Now, what are the modifiers? So again, Sky came up with this 3-axis model, which says that when the patient has shock, you have classified the shock. Look at the different aspects. One, look at the phenotype and the etiology. Look at the shock severity, and look at the risk modifiers, the frailty of the patient, whether the patient had cardiac arrest or not, whether it is acute, whether it is acute on chronic, the different parameters which we need to look into to actually prognosticate that particular patient. Now we look at the phenotype of the shock. What are the clinical variables and the hemodynamic variables? So it could be an acute MI shock, it could be a heart failure shock, which could be biventricular, or predominantly left ventricular, or predominantly right ventricular, or it could be primarily a right ventricular shock, because the management changes. The reason why we need to look at the phenotype of shock is the treatment varies. The choice of inotrope as well as the choice of the mechanical support, which we'll see a bit later, varies depending upon the phenotype of shock. Now, conventionally, one of the important things nowadays when we go to ICU round, probably we'll be looking at the monitor rather than touching the patient. But the good old touch of touching the patient to actually differentiate still holds good. A simple differentiation between whether the patient is overloaded or dry, whether the patient is cold or warm, will differentiate the different phenotypes. So the classic shock, we know, patient is breathless and cold peripheries. A dry patient is a euvolemic cardiogenic shock. A vasodilatory cardiogenic shock is many times missed. The etiology is missed because this patient is breathless in pulmonary edema, but if you touch the patient's peripheries, the patient is warm. This classically will be, say, a high output heart failure, a patient with beriberi, a patient with thyrotoxicosis, anemia. These are the patients who might come in a late stage of shock, but the actual cause is some kind of a hyperdynamic circulation, which might be completely reversible. Of course, if both are not there, then it's not a cardiogenic shock. There's something else which is going on. So looking at AMI versus CHF shock, why this issue, why this discussion about differentiating between AMI and CHF shock? Because the way you approach is totally different, the way they present is totally different. In a AMI cardiogenic shock, the revascularization is most important, and the way they progress to shock is hypotension, hypoperfusion, and congestion. And identify the coronary problem, revascularize it. If not, they're going to ventricular failure and develop the shock. Whereas a patient with heart failure is a patient who comes with a decompensation, that is with LVF, and it is congestion which needs to be taken care of. After congestion, they go into a low output state and then develop a hypotension. So both the presentation and management will be different, and the prognosis is different. AMI has a much higher rate of mortality compared to patients with heart failure shock. And if they have a out of hospital cardiac arrest, you can see it almost doubles. Whether it's heart failure or MI, if they had a cardiac arrest outside, the chances that the chances of mortality actually double. So this is the same thing again to show you that if it's MI, take him to the cath lab or give thrombolysis, revascularization is primary. Whereas if it is a heart failure, get the fluid out, reduce the load on the heart so that the output increases and the hypoperfusion decreases. So how do we finally manage in case after all this discussion, where is the need? Why we need all these classifications? Because the management changes. So this is in one chart just describing how you escalate the therapy. If you look at heart failure versus acute MI shock, acute MI shock, your threshold for putting in a temporary mechanical circulatory device is much less. So even at the beginning of shock, you might put a Iabp, versus in a patient with heart failure, you might still want to decongest, give inotropes, and then move upwards. And once they reach classic shock, then start with Iabp. Whereas in a patient with cardiogenic shock, in a patient with acute MI cardiogenic shock, you tend to escalate the mechanical circulatory device very fast. Put in Iabp, the patient is deteriorating, immediately go to Impeller, Tandem Heart. And of course, once the patient is deteriorating or extremist, there's hardly any difference between what you'll use. It is the same common methodology, which is again described here. I'm sure some of the next speakers will talk about this, about right ventricular, biventricular, how you decide and how you try to wean off, and what is the mechanical circulatory support of choice. I won't go into details regarding this particular management. So let's come back to our patient. So this patient, as we mentioned, this is 10 o'clock in the night. The pulse is 110 and BP is 100 by 70. And what would you do next? So trust me that many a time, about 10 years back, probably this patient, we would have just told the nurse or the resident there to monitor the blood pressure, and next day morning we get up, come for the rounds, and then realize that the patient is in hypertension, and whatever drugs we give, the patient is not improving and has almost gone into a resistant shock, and the lactates have gone up to 10, 15 with a pH of around 7. The reason for that is because you have missed impending shock, or you have not identified a shock which has already set in, but is not obviously evident. So in this particular patient, if you look at the heart rate is around 110 and systolic blood pressure is around 100. So already he is hovering around that shock range. The shock index is more than 1. This case, we actually did a ABG, and his pH was 7.2, bicarb was 18, lactate was 4. So this patient is actually in class C shock. So a patient where it appeared as if the patient is in normal blood pressure with a very good revascularization done, and we are out of the woods. This patient is actually in class C shock with a systolic blood pressure of around 100. Why does that occur? That occurs because the blood pressure is dependent not just on the cardiac output, but also on the systemic vascular resistance. So this patient would have pushed up the SVR, cold peripheries. So your blood pressure is still normal, but the cardiac output has actually dipped to the level of shock. And this was an elegant paper where they showed the shock group, which showed that depending upon the cardiac power output and the lactate, you can actually prognosticate the patient. So if it's equal to or more than 4, even if the cardiac power output is normal, there is only 50% survival. So this patient, we didn't do invasive hemodynamics, but even if the cardiac power output was normal, the risk of mortality in this patient was 50%. And if it was less than 0.6, the survival is 31%. Of course, if it's less than 4 and the cardiac power output is good, then almost all survive. And if the cardiac power output is less, even though the lactate is normal, there is hardly around 65% survival. So again, lactate significantly helps in prognosticating the patient. So where will this patient fit into? As expected, it is in acute MI shock. And how would we manage this patient? This patient goes into this particular strategy. So Iabp, and if the patient doesn't improve, go ahead with the Impeller. So this patient, we had a Iabp put in, and NIV for pulmonary edema. Patient started improving. Lactates normalized in the next 12 hours, off NIV in the next 24 hours, and weaned off Iabp in 48 hours, and was discharged on day 5. I think it's now around 3 or 4 months post follow-up, and the patient is doing quite fine. So just summarizing, ladies and gentlemen, we need to realize that shock continues to be a dreaded complication with near 40% mortality. High index of suspicion is needed to pick up shock early. SCAI shock classification helps in classifying, prognosticating, and managing patients in shock. Differentiating the different types helps in deciding on timing and type of MCS. And finally, remember that hitting early and hitting hard is the mantra to save patients in cardiogenic shock.
I think, as usual, a very nice lecture. And I think regarding this, any anterior MI, because by the time all these reports come in, you hardly have any time. Somebody requiring inotropes on table, I think we should upfront go ahead with an IAP or any mechanical circulatory support before we wheel him out of the athlete. That I think saves a lot of time and a lot of other things. Secondly, anybody with multivessel disease and a proximal LAD which is closed, requiring inotropes, I think IAP should be put in before we go in. Any other thing?
Yeah, and one of the advantages which now have is the lactate which comes with the ABG. So previously it had to be sent separately, but now it's within a few minutes we immediately come to know whether the lactate is elevated or not. At the other extreme, we just had an angioplasty a couple of days back, and the lactates were actually high, and by the time we finished the procedure, the lactates improved so much that we realized patient may not need anything. So it was the exact opposite of what I showed in this particular patient.
I think just one more comment. I think it's a very difficult decision sometimes to revascularize first or do an IABP and right heart cath before. because I think if you're suspecting impending shock and then we give contrast and the cardiac output index is low, I think we are just, I know it's a difficult thing, but in this case, 8-hour window was done. There was no impending arrhythmias and no active chest pain. Please correct me if I'm wrong, but I think it's a difficult call. But I think I always feel that should we revascularize first, or should we just get all this information and then decide should we revascularize or just establish perfusion?
Yeah, actually, almost every 3 days in the morning report, there is a discussion about this. 50% say we should have revascularized first, and 50% we should have put Iabp first. But it's a difficult thing to answer. But if the patient is hemodynamically unstable, it becomes easy actually, because we upfront put Iabp. But when the patient is hemodynamically stable, but as Anuj was mentioning, it's a severe TVD, you're going to open one of the vessels. Do you want to upfront put Iabp and then do, versus finish off the revascularization? You have the advantage that the sheath is there, you just exchange for the Iabp. So, yeah.
3 times, I think both of us are operating and we've simultaneously done both together.
Yeah. One doing angioplasty and one putting in the Iabp.
Dr. Rajiv, this is
Sir.
Dr. Rajiv.
Yes, sir.
Can I say something on this?
Yes, sir.
See, for decades, we got stuck with the window period of 6 hours, 12 hours and all that. In individual patients in shock, each patient in shock is not the same. They're different. Accordingly, the individualization and the clinician's wisdom will decide what is to be done immediately and simultaneously, whatever it is. So that individualization is the key. Clinical trials won't answer in these issues. Thank you.
Any other questions from the audience? Not, then I think thanks, Rajiv.
Thanks.
We'll ask Muthiah to go ahead and present his lecture on advanced heart failure in clinics, medical versus device therapy.
Thank you, sir. Can you see my slides, sir?
Yeah. We can hear you and see your slides here.
Sure. Sir, so I think we're just setting the stage for subsequent discussion on who needs a mechanical circulatory device. So what are the options we currently have for patients with advanced heart failure in terms of medical and device therapy? Now, the last 2 years, we've seen this 4-pillar concept for heart failure management in terms of medical therapy with your ARNI, beta blocker, mineralocorticoid antagonist, and SGLT2 inhibitors. But oftentimes we find that sometimes this is not enough for patients with refractory heart failure, and we are sort of stuck either giving small doses of all 4 drugs, and it's difficult to optimize the therapy in all patients. And one of the main reasons for that is each patient with heart failure has a slightly different phenotype. And not only using these 4 baseline drugs, but there are roles for diuretics, ivabradine, hydrolysine nitrates, and now vericiguat as well. So the way I'd like to do this is just a few clinically challenging heart failure situations that we have problems managing. One is patients with heart failure in patients with renal dysfunction, patients who develop diuretic resistance over time, patients with LV dysfunction and pulmonary artery hypertension, the combination, and patients who have a device, still are not responding to the device. How do we optimize their device? So we'll just go through these 4 things. So 55-year-old male, old anterior wall MI. You can see that the QRS is maybe around 120 to 130 milliseconds. There's underlying atrial fibrillation. The ventricular rate is around 50 or 55 beats per minute. So this man had an ischemic cardiomyopathy, LAD territory was akinetic, LVEF was 25%, NYHA class 4, heart rate was 80, BP was 90/60, creatinine was 1.6, eGFR was 41, and potassium was 4.4. Current prescriptions: he has a diuretic, he has a beta blocker, he has a MRA, he has antiplatelet, he has anticoagulant for the underlying atrial fibrillation, and he has a statin. But this man is class 4. What are the options for this man? So going from Rajiv's talk, I mean, we should sort of evaluate these patients whether even these patients in OPD, they may be in early stages of shock, but maybe most of the time they're in compensated heart failure. So for this person, we started sacubitril valsartan at a very low dose at 25 milligrams BD. On the first day, BP remained 90 by 60. The creatinine went up from 1.6 to 1.7. Potassium was 4.9. Day 4, BP was still around 85 by 60. Creatinine became 1.5. Discharge on day 6 after starting the RNA, and he's on follow-up. So the EF has not changed, but he's in NYHA class 2, and the creatinine is now 1.4. So why I'm mentioning this is the big challenge in treating patients with renal failure is that we feel that the number of medications that we have available to us are less. And the use of, and this is a summary of the drugs and the evidence that I used in renal failure patients, but I would like to just focus on basically one class of drugs, and that is the Ras inhibitors, be it an ACE inhibitor, an ARB, or an RB. Under which level of GFR are we not comfortable to use these medications? Usually, clinically, when the GFR gets close to 40 or 50, or close to 40, we tend to not start these medications. There is a concept of something called as permissive AKI. So once you start an ACE inhibitor on ARB, you're allowed a creatinine rise of up to 30%. And in fact, this rise in creatinine of up to 30% doesn't have any change in long-term outcomes of these patients. The patients get the benefits of RAS blockade with a minimal change in creatinine. And I think that's what happened to this patient too. After starting the medication, there was a slight increase in creatinine. So this is mainly to stress that still ACE inhibitors, ARBs, and ARNIs can be used. Yes, there is no evidence when the GFR starts falling less than 30. But in the 30, 40, and 50 range, you can still consider to use a ACE, ARNI, or a ACE inhibitor. The other difficulty we have with starting these medications in patients who are having renal failure is that already their potassium is high. Sometimes they'll already be on an MRA, and we won't know how to start this in a patient with borderline potassium. So when they looked at a subset of the original paradigm HF trial, and they looked at the MRAs in comparison with enalapril, so MRA plus enalapril versus MRA plus ARNI, they found that the potassium elevation is less when you combine the MRA with an ARNI compared to enalapril. So why is this so important? There is evidence that you can even try to use potassium binding resins to bring the potassium down so that you get the benefit of these drugs. It doesn't have to be only the ARNI, even if it's an ACE inhibitor or ARB, because these are potentially mortality changing medications for most of these patients. So patients with renal failure, borderline blood pressure, there is a role for these medications. Maybe it can be started at low doses, and then we need to monitor these patients on a closer follow-up. The other option for patients who are having renal failure in terms of advanced heart failure therapy is to offer ultrafiltration for these patients. Now, ultrafiltration is different than normal hemodialysis because you're pulling out isotonic fluid. So your subsequent activation of the renin-angiotensin system is not there. So you're reducing your peripheral and pulmonary edema without a activation of your renin-angiotensin system. So this is an important role, and sometimes we feel that ultrafiltration should only be used for patients where creatinine is 3, 4, and they are in end-stage renal disease. There is a role for ultrafiltration just in terms of elevation of your peripheral and pulmonary edema. We have a few patients where we have started these patients on peritoneal dialysis. These are mainly patients with cardiorenal syndrome. Creatinine will be somewhere between 2 to 3. EF will be to 20 to 25%. But I think the caveat, and I think you'll agree that there is a time where this is the correct time to initiate these patients on peritoneal dialysis. This is usually when they're clinically stable. Once they start decompensating frequent heart failure hospitalizations, we've actually had a bad experience in few patients where we have sort of initiated peritoneal dialysis too late, and the patient didn't really get any benefits in terms of heart failure hospitalization reduction as well. The other problem that we have in some of these patients is, let's say you have a patient with recurrent heart failure, lot of peripheral pulmonary edema. They are on Lasix injection. Maybe sometimes we even go up to 15 milligrams per hour, but they are steadily having a reducing urine output. So what are the options for these patients? These are the patients where they have diuretic resistance. Now, there's no clear definition of what a diuretic resistance is, but if you are not able to produce enough urine or reduce your extracellular volume, with the same dose of diuretics, you per se have diuretic resistance. And it's not as uncommon as we think about. It supposedly happens in 1/3 of the patients with CHF. So what can we do about this? Now, the main thing to look at is there are multiple reasons for diuretic resistance. The main thing that we often talk about is this breaking phenomenon that happens in the loop of Henle. The reason is your loop diuretics keep acting in the same place, and as a compensatory mechanism to their sodium resorption in the loop of Henle, there is hypertrophy of your cells in the distal convoluted tubule. So the sodium that is let go at the loop of Henle is reabsorbed at the distal convoluted tubule. So this is why these patients over time, their urine and sodium, their fractional excretion of sodium comes down, and their urine output also comes down. So what can we do about this? This has been described multiple times. The easiest way to manage diuretic resistance is simply to add another medication that works at a different part in the nephron. It can be a thiazide, it can be a mineralocorticoid antagonist, but the ability of these drugs to also block sodium resorption in the distal convoluted tubule prevents this breaking phenomenon and sort of makes your loop diuretics also more efficient or to work. There has been, we've not tried this for any of our patients, but there has been a concept of using a hypertronic saline or a 3% NaCl. And the idea here is, in a patient with heart failure, if you fill your intravascular compartment, that is what a hypertonic saline will do, you will be to do one of two things. You will increase your renal blood flow, but you will also, because it is a hypertonic saline, you may be able to pull in water from your interstitial space. So in terms of patients where you feel the diuretics are not working as well, this is also, this is slightly difficult to, it's opposite to what we usually think about. But a hypertonic saline will also help you sort of to improve the efficiency of your loop diuretics. A 60-year-old male, ischemic cardiomyopathy, narrow QRS, heart rate is 70, BP is 110/70, echo LVEF is 25, RVST is 60 plus 10, which is 70 millimeters. Patients already on optimal beta blocker, ACE inhibitor, SGLT2 inhibitor, and Iabp. So what are the options for this patient? So it's quite a common presentation for a patient with an ischemic cardiomyopathy, where they have an elevated pulmonary artery pressure. So the patient's symptoms are often more, and compared to someone who had not much diastolic dysfunction or didn't have much pulmonary artery hypertension, these patients are usually more symptomatic. So the current treatment molecules are purely looking at the PAH pathway. The problem here is most of these patients already have elevated left atrial pressures, and when you give a molecule like sildenafil or per se, you may expose these patients to developing pulmonary edema. This CGMP pathway has been recently looked at in terms of heart failure management, and this new molecule Viriciguat that is now available for us. It's an oral CGMP pathway signaling molecule, and it works synergistically with the nitric oxide. This is an important molecule because they have tried multiple molecules in terms of CGMP pathway molecules to see what will work in heart failure. Molecule that has really showed a reduction in heart failure hospitalization and the reason is three things. The mechanism of action of Viriciguat is such that it doesn't really reduce your systolic blood pressure much. In the original trial, the reduction in systolic blood pressure was only 2 to 3 millimeters of mercury. But the main caveat before using Viriciguat is you need to make sure the patient is already diuresed well. that you have reduced the filling pressures on the left side before you introduce this molecule, because there is a mild reduction in pulmonary artery pressure that works with this molecule when you give it in patients with heart failure. But the left side has to be as clean as possible before you try to initiate this medication. So these are not simple molecules to initiate therapy. You need to think one or two times before you start the patients on this. The last thing I just spend 2-3 minutes is the cardiac resynchronization therapy has really changed the outcome for many patients with heart failure, where you have a patient where QRS is more than 150, there's a left bundle branch block, and there's an EF less than 35%. So this electrical problem with the left bundle branch block, if it is corrected with a RV lead and a coronary sinus lead, you are able to resynchronize the left ventricle septally and lateral wall, and you can sort of bring this patient back to at least to a near normal ejection fraction. So the problem is many patients, even after you implant the CRT device, these patients continue to be symptomatic and continue to be in heart failure. So this is a few things to look at. So what do we mean by biventricular pacing? Each beat that is done by the CRT device is a biventricular paced beat that is a combination of RV pacing and LV pacing. So every beat that is biventricular paced is good for the patient. Any beat that is not biventricular paced is a loss of pacing for that patient. In these kind of patients, when you lose biventricular pacing, you are actually losing the effect of heart failure therapy for these patients. So the most common reason for reducing your biventricular pacing is usually underlying atrial or ventricular arrhythmias, or a change in your paced and sensed AV delay. I won't go into all of it, but just to understand that when you put in a biventricular device, each heart failure patient is different. Each patients require a different AV delay, and it also depends on their filling status as well. But the goal is that you should be able to achieve fusion between your intrinsic, between your AV conduction, your RV lead, and LV lead. So a narrow QRS that you achieve post CRT implantation is an idea that you have resynchronized this heart optimally. One thing to look at is in some patients you need a AV delay has to be optimized. And the reason that is, in heart failure patients, sometimes the normal AV delays that we set at 110 or 120 milliseconds are not good enough for the left atrial to empty into the left ventricle. So here you see a patient at 130 milliseconds after a CRT implantation, you see an E wave and an A wave, but the A wave is not, it's little truncated. That means you have lost that part of the atrial cardiac output for this patient, possibly leading to a non-response to the CRT. If you extend this patient's AV delay from 130 to 200 milliseconds, you now see that the E wave has come out and you now see the complete A wave. So especially in patients with diastolic heart failure with concentric LVH, where this atrial kick has a bigger role to play, optimizing these AV delays in these heart failure patients makes a big difference in terms of outcomes. Any atrial arrhythmia can ruin your CRT response rate. And the reason is let's say you have a high atrial rate, a few of these beats will penetrate your AV node and be conducted normally. So these are few of the things that need to be taken care of even after CRT implantation. This you see a patient with a 60-year-old male DCM, status post CRTD, and has a severe MR. What do we see? We see that the ventricular beats are actually paced, but there is no P wave. This patient has an underlying atrial fibrillation, and possibly because of this atrial fibrillation, this patient has a severe MR. After cardioversion, what you see is this patient has an ascens bi-V paced rhythm, and this severe MR has come down to a mild MR. So taking care of the underlying atrial arrhythmias makes a difference in a majority of these heart failure patients. In patients with refractory atrial arrhythmias, where one cardioversion or one ablation is not enough, in these kind of patients, we do something called an AV junction ablation, where you disconnect the atrium and the ventricle. And this is also another way to optimize your CRT delivery to the ventricles, because no longer do you have to worry about your atrial arrhythmias interfering with your CRT. So there is a role for AV junction ablation and CRT implantation in patients with refractory heart failure with a permanent atrial fibrillation. And this is just something to look at. And we've had a good amount of experience with this. And it does improve the morbidity and mortality of these patients. So this I'll stick. So advanced medical and device therapies need to be tailored for heart failure patients. And renal failure and diuretic resistance is something that we clinically encounter on a day-to-day basis, and they can be challenging in patients with heart failure. And after CRT implantation, even if the patient is not responding or there's no subsequent reduction in symptoms, you need to look at why the patient's not responding and how to optimize the biventricular pacing. Stop.
Okay, thank you. Are there any questions from the floor?
I found patients suddenly because of the decrease in SVR developing syncope, and then in rock stable and doing extremely well and feeling happy about that. They feel extremely nice after starting our. That was one. Second comment was about the diuretic resistance. One of the issues to be looked into is the association with hypoalbuminemia. These patients who are quite cachexic and have hypoalbuminemia, they will have a combination of intravascular volume depletion and accumulation in the extravascular volume. These patients, we have found good benefit with a combination of albumin and Lasix infusion. So those who were, if we just start Lasix, their creatinine keeps going up. But combining albumin with Lasix, they again start diuresing, and once that initial stage of decompensation we are able to control, after that then it becomes easier to treat. Thank you.
Good evening. I just wanted to ask regarding role of ADH antagonist in diuretic resistance. Any experience on it, or have you tried?
Sorry, Tarak,
ADH antagonist, tolvaptan.
Vaptans.
So Vaptans, they do have a role to play. I'm not sure in terms of diuretic resistance, maybe someone else will know better. But there is a role for Vaptans to play. But in terms of their role in diuretic resistance, I'm not sure.
It's specifically important in elderly people. We are focused on one particular disease. For example, if you have a person chronically running at 128, the risk of falls are very, very high in elderly. Gait instability, patients with frontal lobe disorders, all these things, because we are so monofocused on one disorder. It's in the whole biological organ system. So you may not show an outcome in terms of cardiovascular mortality, but in terms of overall well-being, prevention of falls, cognitive decline, all these things are very relevant. So I think even though you can correct the sodium, you may not show immediately a cardiovascular benefit because there are competing causes of mortality here.
Okay, I have a question to Rajiv regarding his last talk. You are concentrating more on lactates when you're treating patient with shock. Why not put a swan in patients? I don't see swan being put in regularly in ICUs. Cardiac surgery, we regularly put in swan, and then we'll be able to manage better with hypovolemic shock or because of cardiogenic shock.
Dr. Sonali will be in a better position. That will be, I am not sure, it will be discussed in some of the talks. All patients with shock should have a swan inside. And then it's clearly shown that invasive monitoring changes the outcomes, especially in patients with cardiogenic shock. But over a period of so many years, we have forgotten the art of using Swan-Ganz catheter. So that's the reason why it's not being used. But your point is well taken. All cases with shock, you should put a Swan-Ganz catheter. But that's more important to calculate the hemodynamics and all that. At the end organ, what actually is happening, lactate is a fantastic measure to look at that. That's the reason why it has to be in addition to that.
I beg to disagree on the use of, because the rampant use of swan doesn't necessarily improve outcome. It's like several things the Western data keeps coming about. Remote monitoring, tremendous reduction of mortality. Now, what do you do with the data? Now, when there's a clinician who is faced with uncertainty, yes, it's required. When you have a person where all hemodynamic variables are improving with a therapeutic intervention, say you started dobutamine, you started IAPP, the patient's all parameters are improving in half an hour, 1 hour's time. I think there will be, in an individual patient, we latch on to a cognitive bias. This patient has improved that. When you make a general statement as a guideline on thousands of patients all over the globe, the risk of intervention, it's not without risk. A patient fully heparinized, a person who is on dual antiplatelets, you float a swan, yes, everything will be all right, but he'll die of sepsis at the end of 12 or 24 days. So I think it has to be tempered with caution. When you think that you are unable to make a decision on what kind of, does he need increasing vasopressors, mechanical circuit, that is my take on it, but I'm open to correction.
No, yeah, I think I absolutely agree with what Dr. Narasimhan has mentioned. I don't mean that every case, the moment the pressures are going to 90, you first float the span. You have to individualize the patient, see what's happening. You have started some dobutamine, you have started some noradrenaline, the lactates are all right. It appears as if he is on a positive trend, or you have just put in a IABP and within 1 or 2 hours the patient has improved. There's no point in putting a swan guns. But you are in a situation where you are actually not clear what is happening. One is, say, a patient with severe LV dysfunction now has some fever, or patient came in with a heart failure and 2 days later has developed fever, the pressures are going down. We don't know what exactly is happening, whether it's a pure shock or it's a combined shock. So those type of situations, SWAN is a must. Any patient with cardiogenic shock, even if it is pure, you have started intervening in the normal manner and there doesn't seem to be any improvement, then again, we need to float a SWAN. I'll just quote one example, 1 minute. There was a patient who had anterior wall MI. He had a revascularized LAD, so he didn't require anything. The patient had a redo angiogram and patient was rock stable. After the angiogram, 24 hours later, the patient started deteriorating. And then the patient was having some breathlessness, there was bronchospasm. X-ray was, you're not really sure whether pulmonary edema is there or not. The first thing we could think of, we put in a IABP, the pressures were not improving. We float our SWANs, his wedge was 0. That was the first time that we saw a wedge of 0. What the patient was having was an anaphylactic shock, a delayed anaphylaxis. And then adrenaline and all was started and the patient responded. So in that case, not putting in a SWAN is wrong. At the same time, in every case, again, putting in a SWAN is wrong.
See, I think it's more scientific way of treating a patient with shock is putting a SWAN. See, what you're not only looking at the wedge pressures. You're going to look at cardiac output, you're going to look at cardiac index, you're going to look at systemic vascular resistance.
That's
See,
true.
I have seen a lot of patients, my post-operative patients coming back to your ICU, or your patients who had an MI and shock, and they're on vasopressin and they're on noradrenaline, which is an absolutely contraindicated in this patient. See, if you check the peripheral vascular resistance in this patient, it will be something around 2000, 2500, and you're using 6 ml, 8 ml, 10 ml of noradrenaline. And in those patients, if you start them on dobutamine or something like that, the peripheral vasodilate will be more helpful. So in that way, especially in surgery, like post-operatively, when you do patients on pump, their peripheral vascular resistance will be very low. And then we know what exactly inotropes have to be started. I think it's more scientific way of treating patients.
Yeah, but we should realize that CT surgeons have also gone away from
that's because
SWAN guns now. All are using only.
No, not really. No, that's because of the
no, except in specific situations, I don't think.
That's because of the cost constraint. If you go back to the United States, every patient undergoing CABG will have a SWAN. For sure, especially when you're doing beating heart surgery.
May not be cost, but I think the most recent studies have shown that actually people who use SWAN for every surgery, they are considered slightly of the ancient age than people who use CVP.
Dr. Narasimhan,
I didn't realize that still cardiologists and cardiothoracic surgeons are fighting.
Dr. Narasimhan,
Yes, sir. Go ahead, sir.
Well, I agree with Dr. Narasimhan what he said. The point of view that everybody should use versus not use. With the advent of advances in echocardiography and bedside use of it and Doppler technology available, the need for invasive monitoring has come down. we have information from it, and also use the echocardiogram intelligently and well will help a lot of situations. And secondly, keep hypovolemia in mind all the time, because somebody had a myocardial infarction. The commonest drug that every practitioner gives is intravenous Lasix left and right. And then they come to you, by the time they come to you, they are in hypovolemia. And cardiologists don't look at JVP these days, but at least start looking at IVC and its collapse. That does help. I want to ask Dr. Muttaya about the role of in renal failure you talked about, the role of spironolactone and chlorothalidone of dealing with hyperkalemia, etc., and diuretic resistance and chronic situations. Thank you.
There's a question on the chat.
Did you hear?
Sir?
Dr. Somaraju had a question for you. The role of chlorothalidone. Isn't it?
Sir,
That's the
so-
question, isn't it, Taurus?
Yeah, and spironolactone and potassium.
Spironolactone, chlorothalidone with diuretic resistance and renal insufficiency.
So the chlorothalidone, I'm not sure, sir, but spironolactone has been used. The thiazide, spironolactone, or sometimes people have used acetazolamide also. So chlorothalidone alone, I'm not sure, sir. But MRA, maybe we don't clinically see it because many of our patients are already on a small dose of MRA as well.
There's a question in the chat box.
It's by Dr. Pragati saying, what is the role of SGLT2 in non-algebraic advanced CKD?
So that it's
I suppose it's Pragati, it's with heart failure. Okay. I think if you ask every single practicing nephrologist, if you see some of the patients with renal failure, they go for 10 years with a creatinine of 2. There are some patients who start with a creatinine of 2. Within about another 1 year, they are end-stage renal disease on dialysis. What determines the outcome is the proteinuria. So did this patient have a proteinuria, or it's non-proteinuric renal failure? If you have a proteinuric renal failure, then the fall in decline in GFR, I don't know whether Rekha, someone of the nephrologists are there, very rapid. And one of the important therapies now is number one, ACE inhibitor ARB. I think regression clinics in Europe all over has shown tremendous reduction in proteinuria with very high doses of ACE, like 150, 200, 300 milligrams of captopril were used in some of these patients. And similarly, the second drug is SGLT2 inhibitors. So what decides is non-oliguric CKD patients, they will benefit from SGLT2 inhibitors. I think it can go as low as now 15. Now creatinine clearance of 15, you can probably use.
I just had few comments. One about the PA catheter. Yes, absolutely. Routine use is contraindicated actually. It is class 3. And actually it has caused more harm than benefit. But I think in a shock patient, more than looking at the filling pressures, I think you need to know what's the cardiac output index to decide what kind of MCS you need. Because IABP is not enough for everyone. I mean, I know the IABP is most used and cost benefit might be the most, and it's very easily available. But I think in cardiogenic shock patient, you really need to know what kind of support you need, and do you need biventricular support, and do you need unilateral? If someone is having DCM, chronic DCM, and has cardiogenic shock, that's very different from having an anterior MI whose right side might be okay. So I think that's important. So I feel in a cardiogenic shock patient, having more information is important because you need to make all these decisions in the first few hours. So I think that's my take on it, but definitely routine monitoring, routine PA catheter needed in all the patients is not recommended. I have myself seen a PA catheter, PA artery rupture, which should not be seen in anyone's lifetime. So that's one. The second thing is diuretic resistance. I think we have a very low threshold of saying that a person is diuretic resistant. I've seen patients being on Lasix 40 BD and they are diuretic resistant, and we use metolazone 5 daily. And these patients are chronically having low cardiac output and index, and medications like metolazone, all the thiazide diuretics cause a lot of hypokalemia, inappropriate ICD shocks, and renal failure in these patients. So I think we should be a little bit more aggressive in using loop diuretics before adding thiazide diuretics. That's my second point. And the third one, uptitration of ARNI, I think, is really helped if we are sure that do they need a lot of diuretics or not, because many of these patients get hypotensive because they are on a lot of diuretics. So I think if they are used on minimal diuretics, we can actually uptitrate our ARNIs much more easily.
Thank you. I think we should move on to the next.
We'll move on. So thank you, everyone. So I'd like to thank the panelists, and we'll invite the next set of panelists for the next session, Dr. Swaroop, Dr. Sukesh, and Dr. Uday. So this session, we'll start with a 20-minute talk, just talking about all the percutaneous temporary mechanical support options. And then we'll follow it up with 3 short talks, a couple of cases, and surgical talks. So we're running behind, so we'll get going. And then we'll have all the discussions and questions at the end of this session. So my only disclosure for this talk is that I'm a proctor for Abiomed, but then I'm going to discuss all the devices. So learning objectives, we'll talk about the various types of TMCS, that is temporary mechanical circulatory support devices, differentiate the hemodynamic profiles of these devices, and select appropriate devices for the various indications that Dr. Rajiv and Dr. Bhuttaya have set the stage for. And we'll briefly recognize complications related to these MCS devices. Just a caveat, we'll talk mainly about left ventricular support devices. We are not really covering RV shock in today's symposium. So the main indications are cardiogenic shock, either due to acute MI or due to advanced heart failure, like Dr. Rajiv mentioned. Some other causes for MCS, rarer post-cardiotomy, fulminant myocarditis, and refractory arrhythmias. RV failure, like I said, we're not going to discuss much about. And then these devices are also being used for high-risk protected PCI and structural heart disease and EP interventions, and in the setting of cardiac arrest. So we saw this slide previously, and this is the SCAI stage A to E classification, and majority of the times mechanical circulatory support comes into play for the C, D, and E categories. And some of the speakers might talk about this later, but this is the Intermax profile, which goes where the Intermax profile 1 is the sickest patient who's in critical cardiogenic shock, that's analogous to the SCAI stage D or E shock. And the third one is inotrope dependent, probably in the C to D spectrum. And the Intermax 4 to 7 are more the outpatient people. So again, temporary mechanical support is probably in the Intermax profile 1 to 3 categories. So what are the device options we have? So briefly, the Iabp is the simplest, and it's an aortic device, and we'll talk a few slides about each of these. We'll talk a little bit about the Impeller and the Tandem Heart, which is the only one which is not available in India, and then of course the ECMO, which has been around for a long time. And if you look at these devices in terms of the support they offer or what they're doing, so the descending aorta device is the intra-aortic balloon pump. As we all know, it's causing diastolic augmentation. But there's a couple of left ventricle to aorta devices which unloads the LV, and we talk about the Impeller, the whole family of Impeller devices, as well as the pulse cath device, which is not so much a device for cardiogenic shock, but it is one of the options. And then if you look at the circuit, the left atrium to systemic artery, that's a Tandem Heart, or if you add an oxygenator to that, that's a LAVA ECMO. We'll look at that, the graphics for that. And the peripheral VA ECMO is a right atrium to systemic artery support device. So the Iabp is the oldest device available for decades, helium inflated balloon that is gated to the ECG. either electrically or just through the waveform. And this is pneumatic counterpulsation. It's extremely widely used, mainly because it's the most cost effective. The cardiac output augmentation is quite small, often less than a liter, but it's helpful in decreasing the afterload, the systemic vascular resistance. And it's doing that by inflating in diastole. And if you look at the diastolic augmentation, the aortic end diastolic pressure is lower after this augmentation, and that allows for better coronary perfusion. So it's a great device in the setting of an acute MI where myocardial oxygen delivery is an issue and offers early support. And it's probably the quickest device you can put in, both in terms of speaking with families, in terms of cost constraints in settings such as India, and in terms of ease of putting it in. You can do it bedside as well. And if you look at the pressure volume loop, so the pressure volume loop is plotting the pressure on y-axis, the LV pressure on y-axis, and the LV volume on x-axis. It does shift the pressure volume loop leftwards, which means that there's less volume in the left ventricle and there's less pressure. And the area within this loop, actually, that's the PVA, pressure volume loop area, represents myocardial work that is being done. So it doesn't greatly reduce myocardial work, but it does move the PV loop leftwards, which is what we want with some of these MCS devices. Multiple companies make it, multiple sizes are available. You've got to look at the patient's height and decide what to do with it. So we'll move on to the next set of devices, left ventricle to aorta. So if you look at the PulseCath device, which was designed in Europe, it's now owned and marketed by Terumo Europe. This is very much like the Impeller. It has the tip of the catheter is in the left ventricle, and it aspirates blood from the left ventricle. There's a bidirectional valve that sits in the ascending aorta that opens and dumps the blood out in systole. So during systole, it's assisting the left ventricle, aspirating from the left ventricle and ejecting into the aorta at the same time. So the benefit of this is that it's less expensive than an Impeller. It's probably half the cost, and it can be connected to a regular IABP console. And the reason for that is the pump that is driving the mechanics of this device is just a pneumatic pump that is extracorporeal. That is, it's outside the body. It delivers up to 2 liters of flow. So this is probably similar to an Impeller 2.5. The major downside is that it is a very large catheter, a 15 or a 17 French arterial sheath. So this is bigger than an Impeller access site. So vascular complications are a problem. And it's pulsatile flow, unlike the Impeller, which is continuous flow. I'll just show you a picture of this. So this is the nitinol coated bidirectional valve. I have a video. Let's see if that plays. So this is the video the company puts out. So in systole, it's ejecting this blood, and you see that the valve opens only in systole. And this catheter is then connected to the outside, where this pneumatic pump contracts. I think it's somewhere at the end of this video. Yeah, there. So the pump is beating with the heartbeat and working only in systole. And this was a case that was done here. This was sort of a high-risk PCI with cardiogenic shock that was done. So you see the sheath that is placed in the descending aorta is large. And just like an Impeller, it's placed into the LV over a wire. It doesn't have a pigtail at the tip. It has a large inflow bore that sits in the left ventricle. And Dr. Swaroop and Dr. Prasad Reddy sir can talk a little bit about their experience with this. So the other catheter that works again with the same principle, LV to AO, is the Impeller. That's probably more widely used worldwide. This is available in North America. The PulseCath isn't. So this comes, the thing with this is it's one console but multiple catheter sizes. The smallest size is the 12 French Impeller 2.5, which roughly delivers about 2.5 liters of cardiac output augmentation. The real workhorse Impeller is the CP, or the cardiac power, which is a 3.5 to 4 liter augmentation. That's a 14 French catheter, 14 French access site. And then the Impeller 5.0, which delivers 5 liters of fluid, which is sort of in the ECMO and the above the Tandem Heart range, is a surgical device. It needs a vascular cut down, and then an interventionalist can place it. So it's a hybrid device. And there's also a left direct, which is directly placed by the surgeon into the LV. And the difference is that this is a continuous flow device. It's called microaxial because the motor or the impeller is all housed inside the catheter and it's inside the body, unlike the pneumatic pump that is outside the body for the pulse cath. And in terms of placing these catheters, it's relatively easy. Both the pulse cath and the impeller, you're just putting a pigtail into the left ventricle and exchanging over a wire. But let's look at the hemodynamic effects of both of these devices, the LV to AO devices. So as the flow increases, you're pushing your pressure volume loop further down to the left, and you're decreasing myocardial work because the pressure volume area decreases. So the more support you get from the catheter, it's better for the heart. So you've got to choose based on how much support that heart requires and how much myocardial recovery that heart requires. So as Dr. Rajiv mentioned, in acute MI cases, if the goal is to unload, you're doing it early, an Impeller 2.5 may be sufficient. But if significant shock has set in, either in the setting of an acute MI that's delayed or severe underlying heart failure, you may require more support. And again, this is easy to place in the cath lab. This is a cath lab procedure, 14 French access. Sometimes if you need, you can place antegrade perfusion for limb protection, especially if you plan on leaving this impeller in for like a week or 2 weeks beyond what the company would even recommend. And we've also seen utility in the high-risk PCI group where the access site allows for concomitant 6 French guide placement for just single access high-risk PCI. So these are just pictures from one of Dr. Rajiv's cases. So standard, large access, look at the arteries, pigtail into the LV, exchange over a wire. So placement is fairly simple. And in this case, we have a swan guiding the decision because this was a case where we upgraded from a balloon pump. So these kind of decisions where there's a lot of money involved and it's a big investment and decision for the family, this kind of hemodynamic data and objective data are sometimes helpful. We sort of went over these technical considerations. So there is a controller and we may have the module for everyone to look at that is external, that is by the bedside, and the power goes from P0 to P8 and if you're doing PCI, you have a high sort of a burst setting where it's at max speed for a short period of time. Further technical details are, I think individually one can learn for each case. Positioning is important, and this is where the critical care teams and the anesthesia teams that might manage these devices, because this is one of the device we may leave in place, unlike the pulse cath, which is not really designed for use in the ICU. This you may leave in place for a week or so, and this can keep the intensivist or the cardiologist on call awake all night because you can get a lot of suction alarms if the LV is underfilled and you may need to give fluids, or if the catheter tip is touching the ventricle or the mitral valve apparatus, it can cause problems. So bedside echocardiography is very helpful, where there's a certain marker that we want at 3.5 to 4 centimeters from the aortic valve plane. And this is what the screen looks like. It's fairly intuitive, but then it's helpful to learn what the motor current is, which is, if it's functioning well, it should have this sort of waveform. And then there's a placement signal, which is showing sort of a pseudo LV signal and a pseudo aortic signal. And once you have this signal, you know that it's working okay. It tells you how much liters of support it's providing, and alarms display on the top. Now, complications that are specific to the impeller and the pulse cath, both are hemolysis can occur more so with the impeller than the pulse cath because it's a microaxial pump. And persistent hemolysis is one of the key limitations of using these kind of devices if there's acute kidney injury, worsening anemia. Positioning is important. Sometimes arrhythmias can occur because of contact. Aortic insufficiency has been reported because this is a retro-aortic device. There is, after all, a device sitting across the aortic valve, and if it's sitting there for several days, rarely it can cause some problem. And peripheral arterial disease is a consideration. And to overcome that, axillary placement with a graft, those kind of options have developed. We'll move on to the Tandem Heart, which I think to this audience in India is people are not going to be familiar. But the idea is, again, you're trying to unload the LV And what you're doing is you're taking an inflow cannula in the left atrium, you're bypassing the LV and dumping that blood out into the aorta. So this was designed in Pennsylvania by a company called Cardiac Assist, and it's now acquired by Livanova in UK. Again, this is an extracorporeal pump. Like the ECMO, the pump is outside the body. It's a continuous flow pump, centrifugal pump. So it looks very much like the ECMO. The difference is there's no oxygenator. If you add an oxygenator, it becomes a LAVA ECMO, which is a left atrial to systemic artery ECMO. So it's a pump that's diverting blood from the left atrium to the aorta, and I'll show you this picture. So the way this is also, I mean, this certainly requires a lot more skill than placing an impeller, because this involves a transeptal puncture in the cath lab, and a large bore cannula, 15 French cannula, is placed into the left atrium. And this cannula, and I'll play this video here, this cannula has side holes and end holes. So it's diverting oxygenated blood from the left atrium, and it comes out outside the body, and the circuit dumps the blood back into the descending aorta. So when you put blood back into the descending aorta, that does increase the afterload a little bit on the heart. But a lot of the preload is reduced by the inflow cannula. So it sort of works together. So the main problem with ECMO, and we'll see that, is it purely increases afterload without unloading the LV. The Tandem Heart is like an ECMO, but it's also doing the LV venting because it's bypassing the LV, and it allows a lot of time for myocardial recovery. So if you look at the pressure volume loops here, it's different from the AIG. So as the flow increases, you see the pressure volume loop area actually narrows down. That means that it's allowing myocardial oxygen consumption is the least with the Tandem Heart. This is for a given flow of around 4 liters. But when you look at, say, the Impeller 5, which is giving 5 liters, or one of the central ECMOs, which is giving even more support, there the rest that the heart gets is even more. So that's the one difference here. So as you see, actually, and the Tandem Heart patent is for this device that attaches by Velcro to this pad on the thigh, by the way. But otherwise, it's an ECMO. So we could do this with just a transeptal puncture and a cannula, so that would sort of be like a lab without the oxygenator, or you could spice an oxygenator on if oxygenation was an issue. So again, technical considerations, anticoagulation, just like the Impeller. Movement from so the worst thing that can happen is you do the Tandem Heart in the cath lab, you have a cannula in the left atrium, and during movement in the ICU, that cannula slips out into the right atrium, and then all you have is basically, you're not unloading the LV. It becomes an ECMO circuit without oxygenation. But for the most part, if one is careful about placement and measuring at the groin, the catheter distance, and looking on X-rays, it's okay. Limb ischemia and vascular complications, this is just like an ECMO, so you've got to have the same considerations. The benefit of the Tandem Heart is there is not something sitting inside the left ventricle. It's not interacting with the LV. The arrhythmia risk is much lower, and often you can use this for a little bit longer than the Impeller. So for heart teams, this is, if available, this is often a decision one has to make between an Impeller 5 and a Tandem Heart. So you'll notice, I think in terms of hemodynamic support, the Impeller 4, or the cardiac power, is followed by the Tandem Heart, is followed by the Impeller 5, is followed by central ECMO in terms of amount of support you'll get. But it has been used for a wide range of indications. Some people have even done coronary interventions with the Tandem Heart, but that seems like a lot of work to do for a coronary intervention. But it's certainly a useful tool for VT ablations, especially if you're considering going retrograde into the LV for the ablation. We'll talk finally about the VA-ECMO that everyone is somewhat familiar with. So here you have an inflow cannula that is draining deoxygenated blood from the venous side, and that's pretty much the only difference from a Tandem Heart. Then it goes to the same sort of centrifugal pump, and additionally, of course, you have an oxygenator. It's oxygenating this blood, and then it's putting it back into the aorta, and it can give up to 4 to 6 liters of blood or support. And this depends very much on the size of the cannula you take. So how much ever the inflow and the outflow you're putting through the pump, That's the amount of support you're giving. Because these pumps that we use, the Rotaflow or the CentriMag devices, are basically surgical devices. They can go up to 10 liters per minute. And again, now this is the exact opposite as the Impeller. So if you look at just ECMO alone, you're not unloading the LV and you're putting blood back into the aorta. So you're increasing afterload. So here in the blue is baseline and minimal amount of support. So 1.5 liters of ECMO support is here. And as you go higher on ECMO support, the PV loop goes upwards and rightwards, which is detrimental. You want it to go downwards and leftwards. So this brings us to the point that whenever you have ECMO and you want the LV to recover, you need something to vent the LV. You need to unload the LV. ECMO alone is going to keep your patient alive and oxygenated with perfusion and oxygenation, but it will not allow your LV to recover. You will need an additional device. And the simplest device is probably a balloon pump, and I'll show that on the next slide. So here we are comparing, this picture shows central cannulation, which Dr. Naresh will talk about, and peripheral cannulation, which I just described. And because the arterial cannula is large bore, 17 to 18 French, you always have to protect the leg perfusion with the antegrade perfusion catheter. And when you want the ECMO to be there for a long time as a bridge to LVAD or a bridge to transplant, it's useful to consider an ambulatory sort of cannulation where the inflow cannula goes into the jugular vein and the outflow cannula goes into the right axillary artery. So these patients can then walk with an ECMO sitting inside them. So one consideration people always worry about is the Harlequin syndrome or the north-south syndrome. And this is a function that happens as the left ventricle recovers. If the left ventricle doesn't recover, all you have is oxygenated blood coming from the ECMO, and that goes from the aorta. It supplies the entire lower half of the body, but that because of the pressure, it will flow upwards and supply the upper part. But as the left ventricle recovers, there is some deoxygenated blood coming through that then the left ventricle ejects, and it goes and supplies deoxygenated blood in the top. And the best way to detect this is the right radial artery, because that's the site that's farthest away from the ECMO flow in the descending aorta. So if you have deoxygenated blood, the right radial artery is going to be the one showing the lowest saturation. So this is something to consider. And then, as I mentioned just before I end this talk, LV venting is very important, LV unloading. And the simplest way to do that is with a balloon pump. Dr. Sachin will talk about a case where an ECMO and Iabp was used. The other way you can do that is to use a Impeller device or one of the LV unloading devices where you take blood from the LV and put it into the aorta, and that's called an Impeller. Dr. Bhishma will discuss that. Sometimes you could add a cannula into the left atrium. That is pretty much what a Tandem Heart does. But sometimes we can have the surgeons put in an LV apical vent or a pulmonary vein vent. Those are called surgical techniques. So unloading is important. Unloading is the only thing that allows the heart to recover. So this is the table for reference, comparing all the flows of all the devices, the size, arterial and the venous cannula size that you need, the amount of hemodynamic support, the limb ischemia risk as the cannulae are large bore, it worsens, and then the cost. I think the most important, most expensive on this spectrum is the Impeller. The least expensive is the Iabp. Tandem Heart we don't have, but ECMO falls somewhere in between, and then pulse cap falls just outside of that. And I think Dr. Rajiv showed this slide. As we need more support, you've got to drift towards the Impeller 5, the Tandem Heart, and the ECMO, with perhaps even central cannulation. And then with both the Impeller and Iabp and the ECMO, you can use this for ambulating patients when you go the axillary route. And this is something to consider when these patients are waiting as a bridge to VAD or transplant. So these are just slides on high-risk PCI, structural heart interventions, and VT ablations that can be done with these devices. That's not the focus of our talk today. And as I mentioned, I'm not talking about the RV support devices because we're not really covering RV shock, but these are the Impeller RP and the Protect Board. We'll end this here. And this book the Interventional Cardiology Clinic's book dedicated to mechanical circulatory support by Brian O'Neill is a very helpful reference for all, for anyone interested in reading. So we'll stop here and we'll take questions at the end after all the speakers. Dr. Sachin can come up on stage for the next talk. Any comment from the panelists meanwhile? We'll go ahead.
Extensively covered and nicely summarized, Ras. In the interest of time, we'll take questions at the end.
Good evening, everybody. This is the case where we needed an VA-ECMO support to manage a cardiogenic shock in this patient of incidental ventricular tachycardia, and this is fully a team effort, and I am presenting on behalf of cardiology, cardiothoracic surgery, and critical care team. So this patient is a Narasimhan sir's follow-up patient from over last 9 to 10 years. He's a 34 years now with non-ischemic cardiomyopathy and heart failure with reduced ejection fraction. He had one VT ablation about 9 years back and VADs guided the sympathetic denervation. History of he had a LV thrombus with severe LV dysfunction. He had a CVA and renal emboli about 3 years ago. He was on anticoagulation. Unfortunately, he had an episode of VT during this COVID. So where the VT was below the detection zone of this is VT running at about 160 beats per minute. So this VT is below the detection limit of the ICD. So what does it mean is the VT is not treated. So this person was running this VT for over a period of about 50 hours, 48 to 50 hours. So you can see here his monitor zone is between 130 to 162 beats per minute. It was less than that 160. So although it detects that VT is going on in the ICD, but it will not treat it. That's something called as a monitor zone. We keep it to see here. I'll show you. You can see it the extreme end here. So it will detect a heart rate that's more than 133 beats as a VT, but it will not treat until unless it crosses the upper limit here. So he was running a VT and he went into when he reached here, he was in a cardiogenic shock. So then in the ER, he was converted with a DC cardioversion and sedation. The moment cardioversion was done, he slipped from stage B to stage C. We had an elaborate discussion about the cardiogenic shock classification so far. He had biventricular dysfunction, ejection fraction of 20%, global hypokinesia, mechanical ventilation and inotropic support was on. So he was on dabigatran, it was reversed with idursulfimab. Right heart cath and IABP was done in the cath lab. He was placed immediately on the IABP and he was supported with IABP, and with this IABP support and inotropes, his cardiac index came to 2.9 liters per meter square. He was maintaining on the borderline. We're all happy. But the next day, he had a renal shutdown, metabolic acidosis, needing a CRRT, decreasing cardiac index. It came to 1.7 liters per minute per meter square. Despite of all that, he slipped into a stage D cardiogenic shock. So he was, fortunately, he had no episodes of a ventricular tachycardia on amiodarone and lidocaine. So VT ablation was not considered at this point of time. Now the consideration was about the mechanical support versus heart transplant versus a LVAD. So now we have options here because it's already a severely dysfunctional heart, whether to consider to bridge to recovery, bridge to LVAD, but immediate decision was to he needs a mechanical support for sure. So discussion was about Impeller versus peripheral VA-ECMO. Considering all that, the discussion with the family and their family background, financial background, peripheral VA-ECMO was decided, and plan was to list for a orthotropic heart transplantation. So there is a renal shutdown, so all that complicates whole issues here. So then the next is to why was the ECMO considered over Impeller was because of the cost constraints, obviously, and heart transplant versus LVAD, again the cost issues here. We'll see how did it happen over a period of time. The procedure was, there was some time, so patient could be shifted to the cath lab and peripheral PA ECMO was administered. And you see there is a cannula going into the femoral artery, and the retrograde cannulation of the femoral artery to have a distal perfusion to avoid a limb ischemia, and then the venous cannula. You can see that in the video here. We have a Iabp placed, and as we are discussing about we have a PA catheter here for sure in this patient to monitor the cardiac output, so no discussions on that. So we have, this patient was unloaded by giving IABP. Ideal would be, as Bhishma is going to present with, we needed an Impeller, but cost constraints again. IABP was good enough to unload the ventricle in this patient. So here, whatever we stabilized at this point of time, that doesn't end with this patient. They end up with a lot of complications. He developed thrombocytopenia, bleeding, vascular cytosis, bleeds, hypokalemia. He needed multiple transfusions, blood products, that total of about 25 to 30 transfusions, including blood, platelet, and FFPs. Course was really stormy in the ICU. There were background, a lot of discussions were going on. He is on ECMO and then thinking about getting a heart, getting a LVAD for him. Fortunately, Narasimhan sir was very consistent that he will come out, will just continue with the support, whatever is. So although he was listed for the transplant, heart was also available. At that point of time, it was denied to go ahead. At 12th day, he was decannulated and he was maintained on IABP for another 2 days. So with all this in the ICU care, he developed Burkholderia and Klebsiella. Fortunately, he was extubated and then he was continued on CRRT. There was renal recovery. EF improved to 30%. No further VT episodes, fortunately, during the hospitalization. So he was there in a hospital for rehabilitation for about 32 days. Outpatient cardiac rehab, it's all, he was doing well. And for this, all the finances were arranged by the family, and then Navras was very instrumental in organizing for the crowdfunding. So after all this, he recovered completely. For 3 to 4 months, he was ventricular tachycardia free. And after 4 months, he started having a short runs of NSVTs, and further he underwent a VT ablation. He is doing well. This is a timeline of events in the ICU. On the first day, he underwent a cardioversion, and right heart cath in the IVP on the same day. It was not enough. He went on a VA-ECMO, and then he was supported by ECMO, IABP, CRRT support for about 14 days, ECMO decannulation on 12 days, and IABP removal on 14 days, weaned off from the ventilator, discharged home on 32 days. It was a good effort from all the team to discharge this patient. Is doing well after VT ablation, no more VTs now. So thank you.
So next I would invite Dr. Bhishma to present his case-based discussion.
While Bishma is setting up his presentation, especially these mechanical circulatory support devices are concerned, 4 to 5 important questions one need to ask. What is the cardiac output or the support which is provided? Does it cause direct or indirect LV unloading? And what happens to the coronary blood flow? And what happens to the peripheral vascular resistance? So that kind of gives a good insight which particular device to be used in which particular subset of patients. Over to you, Bishma.
Yeah, good evening, everybody. Now that we know various devices available for the circulatory support, and we just saw one case where they demonstrated excellently how they managed a patient with ECMO and IBP. Now we'll go to the next level where this patient was also on ECMO and IBP, but he required much more unloading. So I'll just show you how we manage this case. So basically, it's a stress-induced cardiomyopathy with stage E cardiogenic shock, for which we used Impeller for myocardial recovery. She was a 28-year-old lady with no known comorbidities, 6 months postpartum. She occasionally had allergies, for which she was managed with antihistamines and steroids. So suddenly one day she had skin rashes with swelling around the eye and lips like an angioedema, and she started having cough. And this is when this cough didn't decrease, the dyspnea worsened, and she almost went into anaphylactic shock, and for which she had to be given IM adrenaline. And soon after IM adrenaline was given, the patient drastically deteriorated. He had acute chest pain and she developed frank pulmonary edema within few minutes. So she was taken to a local hospital in Guntur, where they've diagnosed it as an anaphylactic shock with severe LV dysfunction with an EF of 15%. She was immediately ventilated and she was put on IBP, and she was on stiff inotropic support. Still, the blood pressure was less than 70, almost pulseless, and they have asked the attenders to take her to a higher center for further management. So she came to AIG hospital, and on receiving the patient, she was on mechanical ventilation, IBP, 3 inotropic supports on very high doses, hemodynamically unstable. She had a VF within first 20 minutes of shifting to our hospital, and for which we had to cardiovert her and started on Xylocard infusion. So this is when we thought we had an immediate discussion among our colleagues, where she was a young lady with stage E shock, drastically deteriorating. So we thought we'll lose her within few hours. So we had a discussion, and within the next few minutes, our team has been activated. So immediately she was put on a VA-ECMO. These were the vitals when she came in. The blood pressure of 80/50 with severe tachycardia with diffuse Krebs and cold peripheries. This was one of her ECG showing tachycardia with very high rates, and the monitor showed much higher rates, almost 180, 190 sinus tachycardia. So this was the echo showing literally EF less than 10%. So the heart was literally not contracting there. And this were the chest X-ray showing frank pulmonary edema. So a provisional diagnosis of multifactorial shock was made. The query of anaphylactic shock with stress cardiomyopathy due to the adrenal which was given, or a fulminant myocarditis could be the other diagnosis, or a cardiogenic shock probably with an underlying postpartum cardiomyopathy. Well, like I said, the rationale for putting an ECMO here was a acute shock with severe pulmonary congestion. You can see the effects of the shock already. The patient was going into AKI, poor urine output, recurrent VT-VF, and even on stiff inotropic support, the patient was not able to maintain. the blood pressure. So immediately we have cannulated a VA-ECMO with an antegrade limb perfusion, and again right heart cath monitoring was immediately put in to monitor her further management. So this patient came with IABP. She already had an IABP, so we went ahead and connected the ECMO cannulas, one in the RA SVC junction, and, the other in the left femoral artery. So the right heart cath data after we put in the right heart cath showing severely high PA pressures and wedge pressures of 42 with a cardiac index of 2.8. So once we put in the ECMO, we have tackled the hemometabolic component and we have supported the cardiopulmonary, but we started noticing the effects of ECMO on her. So there was a significant afterload on the left ventricular, and causing left ventricular to dilate and further elevating her wedge pressures, and pulmonary edema not subsiding. And so even though the organs have been taken care of, the shock have been taken care of, but the effects of ECMO started to show even with IBP. So we thought that there should be another option where we need to unload the LV further, which helps to LV to recover faster. So because stress cardiomyopathy needs absolute rest so that it recovers faster. So we again had a heart team meet. Even though we know the cost constraints and all that, we had a detailed discussion with the family. We told her the options of further LV unloading options. So the family immediately accepted for that, and we immediately went ahead and put in a impeller the next day. So like I said, everybody discussed about the pressure volume loops. Once you put in an ECMO, the loop moves towards the right and upwards, which increases the PVA, increases the myocardial oxygen demand, increases the end diastolic volumes and pressures. So this has to move to the left so that we rest the LV and recovers faster. So the options here were, like we discussed again, venting the cannula in the pulmonary artery or the LA, or putting an impeller or a tandem heart. So we went ahead and put a impeller. So you can see all in one frame. There's a ECMO, pulmonary artery catheterization, and an impeller all in one frame there. So again, this is the effect of impeller, effect of IBP decreasing the LV unloading a little. And once you put in an impeller along with ECPella, you can see the PVL moving much more towards the left and becoming more triangular, because the impeller decreases, it's a continuous flow. All the isovolumetric phases are gone, and it is a continuous flow. It becomes more triangular, and it decreases the oxygen demand further, decreases the LV dilatation, and rests the LV further, and helps in fast recovery. So these are a few studies on ECPella where it shows that putting on ECPella early in these subset decreases mortality. So coming to the clinical course of day 3 and day 4, once the ECPella is in, the fluid management was done based on the right heart pressures. The patient was put on CRRT and the ACT was managed appropriately. Chest X-rays started to show some improvement. The pulmonary edema was slowly settling down. Yeah. So again, like I said, the wall tension, everything has come down, and the LV gradually improved over the next few days, and the pulmonary venous congestion came down. The organ perfusion was much better. Overall, the organs are perfusing well and they were recovering better. So these are the X-rays. The next gradual X-rays over the next few days, you could see a drastic improvement over the chest X-rays, where the pulmonary congestion has been totally disappeared. You can see the LV recovery, LV bounced back and it's almost come back to normal. So the LV started to show drastic improvement after 5 days. You can see the LV here. So on day 7, we have decided to decannulate the ECMO, and after the recovery of the LV and the hemodynamics were improved, the inotropic support came down because of the concern. Even though we had an antegrade cannula, the concern for limb ischemia is always there. So we have decannulated on day 7, and Impeller removed the same day because we thought we will maintain the Impeller for another 1 or 2 days, but the issue there was an issue with the Impeller where there was a clot in the motor and the signals were drastically down. So we immediately removed the Impeller also. He was continued on CRRT for a few days, and inotropic support was totally de-escalated. Sepsis was managed appropriately by our excellent critical care team. And at day 10 and to discharge, the sepsis was again managed with proper antibiotics. She underwent daily physiotherapy, blood work was done. We wanted to see what exactly happened and why did she go into such bad anaphylactic shock. To our surprise, there was a C1 esterase enzyme deficiency in this patient, which explains her sudden anaphylactic reactions without any source. So whenever she had some stress in the families, whenever she felt some kind of stress in her body, she had some anaphylactic reactions. This explains all that now. So, and on day 22, she was discharged. She went home walking, and this was the X-ray at discharge. This was the echo at discharge, almost back to normal. Again, this was the timeline of this patient. Day 1, once we received the patient, immediately connected ECMO. A right heart cath was put in, an Impeller was put in, IABP was removed. He was managed with 5 days of ECMO. ECMO was decannulated on day 7. And Impeller removed on day 7, weaned off ventilator and discharged on 22, went home walking in absolutely normal state. So coming to the conclusion, short-term mechanical circulatory devices improve cardiovascular hemodynamics in acute cardiogenic shock patients. Percutaneous VA-ECMO and Impeller provides circulatory support, and rest the LV helps to recover faster. Continuous CRRT and right heart pressure monitoring were crucial. Team specialized in circulatory devices consisting of cardiologists, vascular surgeons, CVTS surgeons, and critical care helps in monitoring and managing complications. Thank you.
We are running slightly behind schedule, so I would invite Naresh to give his last talk in this session.
Good evening, everyone. First of all, thank you for the opportunity. And so I would like to thank the organizing team for finally starting a mini symposium on heart failure mechanical circulatory support at our hospital. So this evening I'll be just briefly talking about the central ECMO and its acute circulatory support. Already my cardiology colleagues have in detail spoken about the case-based scenarios about peripheral initiation of the peripheral ECMO and their useful outcomes in our patients. So there is no conflict of interest, and I would like to start with a small quote by William James Mayo. The glory of medicine is that it's constantly moving forward and there is always more to learn. So saying that, the management of heart failure is day to day is progressing, and a lot of newer modalities are coming up. So we need to be updated and keep learning about the new modalities for betterment of our patients. So coming to the veno-arterial ECMO, the various indications I think everybody is aware of. So we basically use the veno-arterial ECMO as a bridge for the recovery, as a bridge to decision, or as for the bridge as a bridge to durable mechanical circulatory support. And there are basically two ways of initiation of a veno-arterial ECMO. Either one is a peripheral ECMO and then it's a central ECMO. So each one has got its own advantages and disadvantages of ECMO. So I will be confining only towards the central ECMO, where the main indications will be in children and neonates, where the cannulation, peripheral cannulation will be a difficult task. So in that kind of patients, the central cannulation will be very useful. And in those patients, especially after a prolonged cardiopulmonary bypass, where we are not able to wean the patient with the complex surgical procedures, we may sometimes, we may have temporarily have to support on the patient. In those patients, central ECMO is indicated. And in those patients with a already established diagnosed peripheral vascular disease, where initiation of a peripheral ECMO will be more dangerous to the patient, in those patients definitely will sometimes we consider considering a central ECMO. And then complications secondary to the peripheral ECMO, like vascular complications, like vessel dissection, hemorrhage, or mechanical complications, or hematology complications. So there is always a viable alternative is to shift them, to convert them into a central cannulation by either a mini sternotomy or thoracotomy. So basically the central ECMO, we usually put a inflow cannula from the right atrium, and outflow cannula is connected into the cannulated into the ascending aorta, where the patient will be the oxygenated blood will be delivered into the aorta. And sometimes the LV venting also can be done by inserting a RSPV vent, right superior pulmonary vein. So in that way, so it has got a better advantages compared to the peripheral ECMO in terms of good venous drainage and reliable arterial return to the aorta. And there is no the risk of that north-south syndrome will be very less, because directly we are delivering oxygenated blood into the aorta, and better venting of the heart can be done. And of course, it also has a disadvantages because it's more invasive, and there is always a risk of bleeding and risk of infection, because there is a big cannula will be staying directly into the heart, and there will be thrombus formation in the left ventricle and on the aortic wall, because when we are emptying the heart from the right side and directly pumping into the aorta, the left ventricle stays empty with some amount of blood, and which is not contracting and it's not emptying. So there is always a possibility of thrombus formation in the left ventricle and on the aortic valve, and it can embolize, and patient can have stroke and ischemia, limb ischemia. And one more disadvantage is inability. We will not be able to ambulate the patient with central ECMO because of the direct cannulas in the heart, close to the heart. So, saying all this, if you look at these disadvantages, so we should be very careful in selecting a patient for considering a central ECMO, especially non-cardiac patient in a cardiogenic shock when they present to the hospital with indications. So we should be very cautious in selecting. So in a newer frontiers, the central ECMO can be also be used in patients with having uncontrolled sepsis. So this was a case scenario. This was a case where this lady underwent a bilateral pneumonectomy with H1N1 pneumonia, and she was managed with central ECMO for 6 days, and she finally recovered following bilateral lung transplantation. So this is a useful paper where the 39 patients were been studied, where the various mechanical circulatory support devices like Iabp, Impeller, peripheral ECMO, and all these has been used as a temporary ventricular assist devices as for the refractory cardiogenic shock as a bridge for the durable left ventricular assist device. Thank you.
Thank you, Dr. Naresh. the session is open for discussion. So I have few comments to make. So Tandem Heart is excellent, to tell you very frankly. I think the concept of Tandem Heart came through left heart bypass, which has been commonly done during aneurysm surgery. So when patient has thoracoabdominal aneurysms, what we do is we cannulate the left atrium, draw the blood and leave it into the descending thoracic aorta so that the spinal arteries can be protected and patients don't have paraplegia. And the concept of Tandem Heart came from that. And it's very useful, and it causes excellent drainage of the left atrium. Decompression of the left ventricle is excellent. Having said that, see, recently, just for the knowledge, just for information, I'm just telling you, Dr. Narasimhan is aware of it. You know, like, see, myself and Naresh are working in an animal lab in Palamur. Okay, so we are developing an artificial heart. You know, like, basically, there's a group from US and from Kids Warangal and from BITS Pilani, Hyderabad branch. You're all developing an artificial heart. So to test the heart, you know, like to test the heart which is being developed, what we're doing is we are implanting a regular tandem heart type of a device in animals. Recently, 2 weeks back, we went and then Naresh opened the chest. He put a cannula in the left atrium and left a cannula in the descending thoracic aorta. We closed the chest and the sheep got extubated and it survived. We kept it alive for 48 hours and after that we killed the sheep. So Tandem Heart is excellent and I think it has got a bright future. That's number one. Second is regarding the putting Impeller in a patient who's already ECMO. I have a lot of reservations, to tell you frankly. You know, we had a lot of discussions about it. I think the simple way is just decompress it. You know, simple, put a catheter from, you know, like probably from femoral vein into the right atrium, into the left atrium and drain it. That's simple, and just connect it to the inner circuit. That works as good as possible. See, actually the left ventricle gets blood from the left atrium, and left atrium, when you're in ECMO, gets blood from the non-coronary collaterals, which are the bronchial collaterals. That is the deoxygenated blood, and that is the cause of North-South syndrome. See, the heart is, see here from femoral artery you're pumping in, heart is also getting some amount of blood, though we have completely emptied it. And where it is coming from? It is coming from the non-coronary collaterals, which are the bronchial collaterals in the lungs. And that is deoxygenated. And that's why when you put a peripheral ECMO, you have deoxygenated blood going to the coronaries and to the brain. So the two ways of handling it. One is converted to central ECMO.
One has to do a transeptal on a patient with an ECMO, and that's the only thing. Sometimes even putting a swan in a patient with an ECMO can be challenging because there's a lot of inflow drainage happening from the IVC. You already have a large catheter there.
See, one more, just one second.
Bhishma,
No, the first, in fact, Dr. Somraju may remember this patient. The first ECMO we used for a VF storm was about 12 years ago, in 2010 or something, in a child with viral myocarditis. Patient was resuscitated continuously from another center, declared dead, and brought. So as you know, in children, we immediately cooled the patient and went on peripheral ECMO, no brain signs, cerebral signs for a while, and then third day it was converted to a central ECMO. And it took almost about a week, and then the patient recovered quite well. VT storm settled everything. One thing was the limb was quite cold, and the decision was made to amputate the limb. Again, repeatedly the vascular persons were checking the Doppler and saying it's a continuous flow that was going on, and there's misjudgment. Finally, the limb also was salvaged. The kid is now entering college and it's doing well. It is about 2010, I think. The second is the patient of ARVC, which... Yes,
just
doctor.
to interrupt here, the amputation advice was given by vascular surgeon.
I know, I don't want to go into
yes,
this, sir.
The family refused. And then finally the limb was saved.
No, no, I know the thing behind. I'll tell you the thing in private later on. The second thing is the ARVC patient. It's coincidence. 48 hours back, the patient came about 2 days back walking. The wife was complaining he's continuing to walk every day for about 30 minutes and then he develops a cramp, stops and then walks again. That's the only complaint that the guy is having. He has got some minor neurological disability, otherwise he's doing fine.
This you're talking about the patient who's undergone transplant. Oh, right. Any?
Yeah. Predominantly our interaction with the mechanical circulatory support is with the chip procedures and high risk PCI. And PCI is nothing but the high risk, complex high risk intervention in appropriate patients. Basically, it's not a substitute to the CABGs, but predominantly these are the patients you would agree are surgically declined because of the comorbidities, and then you have to achieve a near complete revascularization by minimizing the risk. Ever since Impeller has come, there is a lot of talk about Iabp being not so useful, Iabp is useless, but we shouldn't forget where we practice, and we practice in India, and Iabp still has a role. So suppose you have a stable patient and you are planning high risk PCI, here comes the role of hemodynamics, and you do the right heart study, understand the wedge pressure, simply look at the mean wedge pressure. If mean wedge pressure is more than 70, clinically patient is stable, mean pressure is more than 70, wedge is optimal, and you are not planning an extreme high risk procedure. What I mean is not extensive rota ablation and all. These group of patients do as good with the Iabp, with the support which is provided around 1 liter. But at the same time, if you have LV dysfunction, fragile hemodynamics, and the complex procedure like left main bifurcation PCI with or without rota ablation support, one of Dr. Anuj Kapadia's patient we had similar, then you shouldn't wait in this group of patients where patient kind of deteriorates and then as a bailout you use Impeller. In that case, it has to be used upfront. So each patient, I think you have to individualize based on patient's hemodynamics and type of intervention which you are going to perform. Auras may remember one of his patient, we kind of did a high risk left main patient with the Iabp support, and the exactly same principle we followed.
Okay.
We'll end this session and move on to the next.
Thank you so much, Dr. Sukesh, Dr. Swaroop, and Dr. Uday for being on the panel. So we'll move to the final session. I'd like to invite Dr. Narasimhan, Dr. Rajiv, sir, and Dr. Prasad Reddy on the panel, please. So the final talk is by Dr. Sonali Arora, who's a guest speaker today from the KIMS Heart and Lung Transplant Institute. She has a 30-minute talk on two parts actually: patient selection of for advanced heart failure therapies, including both transplant and VADs, but then to talk about the management of durable VADs. Thank you.
Good evening, everyone. Thank you so much for having me here. It's a great opportunity and an honor to be here and presenting these topics to you. I apologize, I have been given 2 topics which are quite detailed. I might not be able to cover each and every aspect of it, but I think my role is to, my focus is going to be more on patient selection, and then I'll talk briefly on management. I apologize if I skip slides, just in interest of time. Can everyone hear me well? So my topic for today is patient selection for advanced heart failure therapies and management of durable LVADs. These are my disclosures. My objectives are to recognize advanced heart failure, to discuss indications and contraindications for advanced therapies, which are both transplant and LVAD, timing for advanced therapies, and long-term management of durable LVADs. So let's come to these, an MCQ question. Which of the following patients is the best choice for immediate referral for advanced therapies? A 35-year-old woman with new diagnosis of peripartum cardiomyopathy with an EF of 25% on guideline-directed medical therapy, but who is asymptomatic. An 85-year-old male with ischemic cardiomyopathy, EF of 30%, who has COPD with 35-pound weight loss in the last year. 49-year-old female with non-ischemic cardiomyopathy, EF of 25%, blood pressure of 110/80, able to do the ADLs, working currently. And 58-year-old man with non-ischemic cardiomyopathy, EF of 30%, blood pressure of 88/60, recently taken off beta blocker, symptomatic on minimal exertion. I'm going to have these choices with you and we'll come back to this later. So this is a patient whom I had seen on my first day of my first job about 3 years ago. A 58-year-old obese female with history of breast cancer, diagnosed when she was in her 30s. She underwent lumpectomy and lymphadenectomy. She also received anthracycline-based chemotherapy as well as radiation therapy. She had a history of grand mal seizures and has been on anti-seizure medications. She came to see me for shortness of breath and unable to walk uphill, which she could do easily about 2 months ago. She attributed it first to bronchitis, which was treated with a course of antibiotics. She then thought she was deconditioned and did not take her symptoms seriously. Due to persistent and worsening symptoms, she finally decided to take an opinion. She did not have history of hypertension, diabetes, stroke, or hyperlipidemia. She was taking levetiracetam 750 mg twice a day. Other than that, no other medications, no allergies. Surgical history, which I've already mentioned. She is an assistant teacher, no history of smoking, drinks wine occasionally. Father has history of diabetes. Her vitals were blood pressure was 110/75, heart rate 101, oxygen saturation was okay, she was afebrile, her BMI was 36, alert and oriented, JVD elevated, regular rate tachycardic, PMI displaced, holosystolic murmur present, lungs sounded clear, abdominal exam was normal, no edema in lower extremities. Her ECG showed sinus tachycardia, she had a left bundle branch block, QRS was 155. I didn't have any other ECGs to compare from before. Cardiomegaly on X-ray, no pleural effusions. CBC, RFT, LFTs were okay. NT-proBNP was 3000. This is our ECG, and this is our echocardiogram. Severely dilated left ventricle, LVIDD of 7.2, moderate MR, RV mildly dilated, TAPSE of 1.5, mild TR, PASP of 42, trivial AR and PR, no pericardial effusion. She had elevated filling pressures on echo. Her IBC was 2.4, less than 50% compressibility. Routine workup for cardiomyopathy, including thyroid functions, iron studies were normal. Her coronary angiogram showed normal epicardial coronaries. She was started on guideline-directed medical therapy, but it took a long time, about 6 to 9 months, to uptitrate her medications, and even then, she was not on a very high dose of medications. She actually subsequently underwent a CRTD as her EF did not improve, her LV was still dilated, and she remained quite symptomatic. After CRTD, she actually responded very well, and we were able to uptitrate her medications to the highest dose. She went back to work for few hours daily, and after about 1.5 to 2 years of initial diagnosis, her EF went up to 30%, and her LVIDD was about 6.5, down from 7 cm. MR was mild, which was moderate before. She continued to follow up and did well for almost 3 years until recently, when she started complaining of fatigue after she took her medications. Her blood pressure would drop to 80s each time she took her ARNI or beta blocker. We had to decrease her medications, and now she was on the lowest dose of ARNI and no beta blocker. We even tried to space out her medications, and that didn't work. Her creatinine, which was always normal, went up to 1.5. Her urea was elevated. Sodium was low at 128. Bilirubin was 1.7. AST and ALT were mildly elevated. Her echo showed an EF of 20%, which had dropped. Her LVIDD was back to 7 cm. There was actually almost severe MR. RV was dilated, TAPSE was 1.6, her PASP was 56. We did a CPET after we diuresed her, and her VO2 max was 11, and this was on low dose of beta blockers. Right heart cath showed elevated biventricular filling pressures with PVR of 4.5, which was reversible with milrinone, low cardiac output and index. Her PAPI was 3, and her RV stroke word index was 9.5. Patient was diuresed with the help of inotropes, but could not be weaned off them. We discussed advanced therapies evaluation for the patient, and she was discharged on home milrinone as she had an ICD and as a bridge for VAD. So coming to these profiles of hemodynamics, which Dr. Rajiv has already gone over, but he was talking more of shock etiology. I'm talking more about chronic heart failure. So basically we have 4 profiles. The commonest profile which a heart failure present is a congested patient. You diurese the patient. They go from NYHA class 3 or 4 back to 1. It's a dynamic symptomology. A class C or a L patient are the more concerning patients, which are wet patients and they are hypoperfused patients. And the L category, which are dry patients and hypoperfused patients. And those patients you have to think about inotropes or MCS support. So this is the ACC-AHA classification, and I'm sure all of you are familiar with it, but I'm raising it because it's important to know. And this classification is a little changed now. At risk, which is stage A, and asymptomatic, which is also called heart failure now. So stage A being at high risk for heart failure, but no structural heart disease. Stage B, structural heart disease, but without signs or symptoms of heart failure, but they can have elevated filling pressures on the echocardiogram. Stage C and stage D are symptomatic heart failure, which are structural heart disease with current or prior signs or symptoms of heart failure. An important thing to remember is, even if in stage C, the heart failure or the EF improves, they still remain in stage C. They don't go to stage B or A. So once you have entered a stage, you don't go back. So unlike an NYHA classification, this is a fixed classification and a linear progressive classification, not a dynamic classification. So that really helps us when we actually profile a patient who comes to your OPD. And stage D, as everyone knows, is refractory heart failure patient, who's usually a class 4 patient. So I'm sure all of you are familiar with this. This is a usual guideline-directed medical therapy stepwise treatment of a heart failure patient, going from stage A, who has high risk with no symptoms, going to stage B, who has structural heart disease with no symptoms. But if they have structural heart disease, you want to start them on appropriate guideline-directed medical therapy, which have survival benefit. So if they have hypertension, treat them with beta blockers, which have like carvedilol or bisoprolol, and not any other medications. Once they have structural heart disease and symptoms, then you aggressively up-titrate your guideline-directed medical therapy, including ARNIs, ACE inhibitor, beta blockers, SGLT2 inhibitors. Cardiac resynchronization therapy is relevant, revascularization if relevant. Consider multidisciplinary team discussion, aldosterone antagonist, and if and only if you are not able to do any other things, you think about advanced heart failure therapies. So your patients really have to work hard, unfortunately, to reach this level. Because I think if they don't work hard, the benefit in them is not appreciable. So I think it's really important for you to try to go over this again and again till you are sure that I have exhausted all my options and only advanced heart failure therapies is important. Because at the end of the day, advanced heart failure therapies itself have caveats. They have a shelf life. We are not curing the disease process, we are exchanging a process, but with the aim of longevity and quality of life. We have already spoken about Intermax profile. My only important point to speak here is, we spoke about cardiogenic shock profiles, which are your 1, 2, and 3, which are crash and burn patients. Most of these patients, thinking about them, will benefit the most with advanced heart failure therapies. But the crash and burn patients, if you try to do advanced heart failure therapies on them, the outcomes are not good. These patients don't do well if they're decompensated and you take them for an LVAD or a transplant. The patients who actually do well are 4 and 5. These are the patients which actually do well after advanced heart failure therapies. But the issue is, it's again, who will benefit the most and where the risk is the most. So you have to really identify which patients you're talking about. And this classification is important from a physician to physician point of view, because in a second, you know, what are you talking about, where the clinical status and hemodynamic profile is. So that's why these names are important. You know, your profile 1 is your crash and burn. 2 is sliding on inotropes. 3 is dependent stability on inotropes. 4, frequent flyers, and etc. and etc. So natural history of heart failure, if you can see here, this is your time axis on the x-axis and the functional status. And every dip is a hospitalization. Every time there is a hospitalization, the functional status of a patient is not better than before. It's lower than before. So this is not a plateau. This is kind of coming down. Every time there's a dotted line, it's a sudden death event. So if you in between do medications and you are able to stabilize patients, in every heart failure patient, there will be a time for about few years, few weeks or few months that the symptoms will be static. And after that, there'll be more and more hospitalizations. And the only way to see other than your guideline directed medical therapy is from bringing from here to back to the original classification is thinking about advanced heart failure therapies once you have exhausted your GDMT devices and other modalities. I think we all know that there is poor survival with medical therapy alone. This is data from control groups in 3 RCTs. The x-axis is months or time from post-enrollment or post-diagnosis, and this is the percentage survival, which is 1 here. And as the months are going by, at 2 years, the survival is between 0 to 10%. At 27 months, the survival is less than 10%. At 12 months, the survival is between 10 and 20%. So once you have reached advanced heart failure, the mortality is really high. And that's why we are here talking about this. This again is an important slide which kind of tells us the hemodynamic progression in heart failure. The x-axis is the volume and the LV pressure is on the y-axis. Initially, when you have structural heart disease or you have low EF and patient is stage B, it is not necessary that your remodeling has already happened, that your filling pressures will be high. Those patients will be not low cardiac output or index. These patients will be just showing you that they're doing okay, but their end diastolic volume on the echocardiogram will be more. So that means they have already started negative remodeling. That should be something that you should actually follow and monitor. EF is important, but EF is not everything. Filling pressures and EDV is really, really important, which I think all of us kind of sideline sometimes, because you can see as they are going from the left to right and as their end diastolic volume is increasing, gradually the LVDP would increase and stroke volume will increase. Once they are already hypotensive and once their filling pressures are already high, we have progressed from stage B to stage D and we don't even know about it. So I think it's really important on the echocardiogram to look other than the EF on the filling pressures and the end diastolic volumes, your LV-EDD, your RV pressure, your RV size, your TAPC, and as well as your right-sided, your PASP, your pulmonary hypertension. So let's come to some indications and contraindications. So what are the indications for LVAD or heart transplant? I'm sorry, the slides got reversed. So in EF of less than 25% and progressive remodeling on imaging studies, need for chronic intravenous inotropes, persistent NYHA class 3 to 4 symptoms of congestion and fatigue despite GDMT and despite CRT, systolic blood pressure of less than 90, and when especially that hypertension is symptomatic, serum creatinine of 1.8 or urea of 43, recurrent ventricular arrhythmias or repetitive ICD shocks. 2 or more emergency departments visits or hospitalizations for heart failure in an year is a red flag, and you should start thinking, is this patient having advanced heart failure? Inability to tolerate optimal dosing of guideline medical therapy. I think many times we have had patients who have had hypertension and we reduce the medications and the blood pressure becomes okay and we feel nice about it, that now they are okay. But I think it's a red flag that they are not able to tolerate the medications which were able to tolerate. So there is something which has changed. Clinical deterioration and rising biomarkers. Your NT-proBNP is progressively going up despite you making them less congested. Worsening cardiopulmonary exercise test parameters. If some patients cannot have a CPET, just a 6-minute walk test will give you an idea about their functional status. Worsening hemodynamics as assessed by invasive right heart cath, but we can't do this on all the patients. Most of the time, we'll have to go on the echocardiogram or on the biomarkers, and if we are not sure what's going on and the creatinine is going up, we have to sometimes go about right heart catheterization and invasive hemodynamics. High mortality risk using validated risk models. So these are few indications which would actually guide you towards selecting a patient for advanced heart failure or not. So coming to some contraindications, we'll talk about both. Most of the contraindications for VAD and transplant are overlapping, but there are some specific contraindications for LVAD versus transplant. So non-compliance with medical regimen, active substance abuse will be a contraindication for any advanced heart failure. Abdominal aortic aneurysm, severe symptomatic cerebral vascular disease, Inability to tolerate anticoagulation will be a more specific contraindication for an LVAD. Severe dysfunction of other organs, lung, kidney, liver, or coagulopathy. Active infection, again, this is not an absolute contraindication. We are doing transplants in patients who have HIV. We are doing transplants in patients who have hepatitis C, because at the end of the day, they have become chronic diseases and they have been, they have good medical treatment. But it's very important to have an input of an ID physician who will actually be able to tell you what is the viral load, what are the interactions of these medications with your immunosuppressants. So I wouldn't say that this is a straightforward thing that if someone has HIV and hepatitis C, you can go ahead and do a transplant. But I would say to still consider these patients before saying that no, you are not eligible. Active mental illness, there are many patients who will have bipolar, schizophrenia. That does not make it absolute contraindications. We've had patients who have had mental illness, but till they can support themselves, till they can take care of themselves, till they are on a stable medical regimen, it's not an absolute contraindication for advanced heart failure therapies. Inadequate social support, I think, is an extremely important point. These patients cannot do this all by themselves. They really need support of 1 or 2 people in their family or friends whom they trust, who really need to guide them and motivate them through this process. So I think this is really key when you are considering them for advanced heart failure therapies. Morbid obesity, BMI of more than 35 is usually a contraindication, but less so in an LVAD patient. We have done bariatric surgeries and LVAD surgery simultaneously in these patients. For transplant, the BMI restrictions are much rigid. Age more than 70 years, again, is not an absolute risk, but yes, the older the patient is, you have to think twice, 3 times that can this patient undergo this advanced heart failure therapies and will they be able to, go through the surgery. And especially this will be a contraindication more for a transplant versus an LVAD, because immunosuppression in older patients make them more susceptible for an infection. And we can think of an LVAD in these patients if we are otherwise satisfied with other factors. Recent or uncured malignancy especially is a contraindication for a transplant, especially less than 5 years. If there is a malignancy, we cannot transplant these patients. If there's a malignancy in the last 10 years, we need to take input of an oncologist, and only then, if they have a PET scan and if there is no metastatic disease and the initial diagnosis of the malignancy was, did not have a high chance of recurrence or, having micromets, those patients can be considered. But again, in these patients, LVAD might be a better therapy than immunosuppression as compared to transplant, as they'll be using immunosuppression, and immunosuppression itself can cause a risk of malignancy on a long-term basis. So these are few contraindications and indications for advanced heart failure therapy. So most of them are overlapping. The important one to consider for LVAD as a contraindication will be to inability to tolerate anticoagulation. And the other thing would be, if you compare a LVAD population and a transplant population, most of the LVAD patients will have more comorbidities, and most of these patients will be ineligible for transplant for some or the other reason, and then we'll start thinking of LVAD. Most of the time, patients don't like to think about LVAD as a first option, most of the times. And even if they have LVAD, they go as a bridge to transplant. So putting it together, clinical findings, a 6-minute walk test, a CPET, imaging clues on echocardiogram, a cardiac MRI, invasive hemodynamics, if available, will help us in assessing if this patient requires an advanced heart failure therapy or not. So let's talk about timing for referral. So the time is on the x-axis, the severity of illness on y-axis. This is the onset of heart failure. Of course, initially, when you're NYHA class 1 to 2 symptoms, tolerating GDMT, no hospitalizations, no evidence of end organ dysfunction, we can consider referral, but it might be early. But it's good to meet the team when a patient is well and they can actually participate in that decision. But I think it's all right to have these patients, follow up with their cardiologist as they are doing well. So, I mean, that would be an early referral you can consider. But I think the important thing, or the golden window for referral, would be here when they start having persistent heart failure. They start having NYHA 3 or 4 symptoms, down titration or inability to tolerate medications, as I've mentioned, frequent hospitalizations, recurrent arrhythmias, worsening renal function or liver functions. This is the progressive or the decompensating stage. Most of the time, this patient is congested when you see them. Most of the times, you are tweaking the medications either to reduce the GDMT or increasing the diuretics, but still they are not able to do what they really want. And when the patient tells you that, you know, doctor, I'm not able to do what I want, I'm just sitting and, you know, this is not the quality of life I really anticipate or I really want. This is the golden window when you can actually think about referring them to an advanced heart failure center where they can meet the team, not for transplant or VAD immediately, but just to talk to them about this process, because this is not something which will happen in a day. This is a long process which needs a meticulous workup and evaluation. So I think the patient kind of deserves to meet that team, to think about it, to arrange things in case they need it in future. If they don't, that's really great. Referral which could be too late could be multi-organ failure, severe malnutrition, cardiac cachexia, unresponsive to supplementation, which leads to pump failure and death. So we have had patients when we have seen them with, you know, liver dysfunction, kidney dysfunction. Most of the times they're reversible. You know, we give them inotropes, but as soon as they start having multi-organ dysfunction, you have their mortality, you have their outcomes, which are inferior to the patients who are coming to you before. So they become Intermax 2 or 3 rather than 4 or 5 when you actually really want to see the patient. So I think when you go to the OPDs, think about if this patient is Intermax 4 or 5 already, you should start prepping them up for advanced heart failure therapies. So the impact of timing of advanced heart therapies, as I was talking before, is important. If you can see here, this is months since enrollment, and this is the survival, 100 being here. So the red is Intermax 4, blue is 5, and green is 6 or 7. And this is survival free of VAD rescue. And naturally, there will be better survival in Intermax 5, 6, and 7 profiles because these patients are better. So there's always a discussion, do these patients actually need advanced heart failure therapies? So at the end of the day, you have to balance the benefit versus risk. Which are the patients who would benefit from this therapy versus the patients who can actually wait? So this is a fine line, and you need a lot of data to decide that. So doing NT-proBNPs, 6-minute walk tests, CPET if it is safe to do them, I think you should get them once you start thinking that yes, this patient is entering that category of maybe advanced heart failure therapy, because it will take time for us to establish if this is really advanced heart failure therapy or not. So goal of appropriate patient selection would be to evaluate for advanced therapies before irreversible non-cardiac dysfunction occurs, irreversible pulmonary hypertension occurs, and irreversible frailty occurs. I think we don't pay a lot of importance to frailty, but I think it's extremely important because this is not diagnosed easily. These patients come in wheelchairs. These patients are not doing any physical therapy, not exercising at home. They're losing all the muscle mass, but you don't see any weight loss because they have fluid. But actually, they're having cardiac cachexia. So I think we really need to pick these patients before they develop these 3 things for better outcomes after advanced heart failure therapies. So let's come to our second topic. Advanced heart failure therapies, heart transplantation, which remains the gold standard, but I will not be talking about that today. Let's talk about durable LVADs, which will be a treatment for chronic heart failure patients or an acute heart failure patient who has been on some temporary mechanical support or who has been on inotropes, but we are not able to wean inotropes on them, wean MCS on them, and then we think about bridge to a durable LVAD. So this is the evolution of LVAD therapy. It evolved from an engineering dream to clinical reality in 1980s. But after the rematch trial in 2002, the first pulsatile LVAD was approved by FDA, which was the HeartMate XVE. And 2008, the first continuous flow LVAD was approved. And right now we usually use the continuous flow LVADs. We have HeartMate 2, HVAD, and HeartMate 3. HVAD was taken off the market recently because of some pump dysfunction and mechanical failures. So the most common VADs are HeartMate 2, HeartMate 3, and we have also done some pediatric Jarvik VADs. So components of a typical continuous flow LVAD would be the pump, the skin entry site here, which is a percutaneous lead connected to the controller with an external battery pack. There will be the main pump here, which will be which has an inflow cannula and an outflow graft, which is pushing blood to the aorta and then to the body. So here, as you can see, this is the battery which patients wear, a cable connecting the external control unit and the internal VAD through a small hole in abdomen, which you call a drive line. There's a control unit here. This is the inflow cannula. Blood from the left ventricle enters the LVAD and goes to the LVAD, which is the pump here, and then goes to the outflow graft. LVAD pumps the blood into the aorta and to the body. So the circuit becomes like this. So I'll be focusing on management of LVADs on post-operative care and then the long-term care. I will not be talking about a lot about physiology because that is out of scope of this topic here today given to me. So post-operative bleeding is defined as receiving more than 4 units packed red blood cells within 7 days of surgery requiring a reoperation, which is the most common complication after LVAD implantation, with reported rates between 20 and 81%. Preoperative strategies to prevent bleeding include optimizing nutrition and coagulation parameters. Anticoagulant and antiplatelet medication should be discontinued and any pre-existing coagulopathy corrected before surgery. Usually epsilon aminocaproic acid and tranexaminic acid, which are the antifibrinolytic agents, are used to reduce bleeding. And you see intrapericardial devices such as HVAD, Jarvik 2000, HeartMate 3 generally have less bleeding than those requiring the extrapericardial placement. HeartMate 2, usually we start the reduced dose of heparin, which should be initiated in the early post-operative period, which is after 12 to 24 hours, once the chest tube output has declined to less than 50 cc per hour. After 24 hours, the heparin infusion should be titrated gradually to full therapeutic levels over the next 48 hours. We usually have these patients on dual antiplatelets, but many of the centers only follow one antiplatelet agent. Aspirin 81 to 100, in India 75, dipyridamole 75 milligram 3 times a day should start on post-operative day or 2. Warfarin should commence on post-op day 3 or 5, overlapping with heparin, which is extremely important. The INR should be maintained in the range of 2 to 3. Dual antiplatelet therapy recommended, but not all centers follow that protocol. HeartMate 3, again on post-op day 2 or 3, you can start aspirin, and on post-op day 3 or 5, if no evidence of ongoing bleeding, warfarin started overlapping heparin. Novel anticoagulants, the role has not been established in LVADs, and in HeartMate 3, the risk of thrombosis is lower than in HeartMate 2, so the anticoagulation is less aggressive most of the times. Right heart failure is again a frequent complication after LVAD implantation. The incidence ranges from 20 to 50%. Despite having so many right heart failure predictive risk scores, the complications are hard to avoid. RV acts as a volume pump, tolerates volume overload easily, but it is very sensitive to change in afterload and increase in pulmonary artery pressures happen. Left heart failure, when these patients have left heart failure, the RV preload is limited, which can mask the inherent RV dysfunction. Post-successful LVAD implantation, output of RV has to increase to match the LVAD work, which leads to increased RV preload. Therefore, the RV afterload has to decrease to improve the compliance. So inability of pulmonary circulation to fill the LVAD despite medical therapy requiring RVAD or ECMO support, use of inotropic support for more than 14 days actually characterizes and defines right heart failure. It can be early or late, early usually less than 14 days, late after 14 days. So these are all the risk scores which exist to predict right ventricular failure in LVAD recipients. This could be early or post. There is a Michigan RV score, a Penn RVAD score, a Utah RV score, Cormo score, Pittsburgh decision tree, a CRIT score. But most of these scores, INRs, liver, LFTs, creatinine, blood transfusions before the LVAD, RV stroke work index or PAPI on the right heart cath invasive monitoring, a pre-VAD ECMO or Iabp support, which are the risk factors for, so basically if you see these patients, the sicker the patients, the more the chance of RV failure. So how do we optimize pump speed? Of course, it's different for all the VAD, all the category of VADs, and we can have lectures on them, but basically, just to give a brief overview, speed adjustment should be hemodynamically guided to provide optimal end organ function and allow weaning of the vasopressors in the early period as the patient is recovering from the vasodilatory state usually induced by LVAD implantation. In this setting, the care should be taken. You should not set the pump at a very, very high speed to avoid leftward septal shift and induction of RV failure. At this point also, aortic valve opening is not an important goal. At this stage, and higher pump speeds while avoiding RV failure, which will allow favorable LV unloading. And it should be usually done in the OR first, and after that you can do transthoracic echoes. If the windows are not good, you might have to use esophageal echoes. On a long-term basis, usually what are you looking for in a LVAD patient? Adequate cardiac output, adequate LV unloading with pulmonary decongestion, which are the most important things in all the LVAD implanted patients. So you want on an echo a small LV cavity, absence of mitral regurgitation, a closed aortic valve. These three features, if you achieve, will tell you that you are maximally unloading a patient with an LVAD. You achieve it or not is a different question, because every patient will be different, but these are your goals when you're doing an echo on a patient to increase or decrease speeds. What are the other complications after LVAD? I would not say complication, management of comorbidities and complications. Hypertensions, GI bleed and AV malformations, skeletal muscle myopathies, exercise intolerance, renal insufficiency, LVAD pump thrombosis, epistaxis, stroke, aortic dilatation and stiffness, aortic insufficiency. We'll talk about few of them. Bleeding diathesis or GI bleeding. Continuous flow LVADs have shear stress-induced von Willebrand factor deficiency. And the clinical studies suggest that decreased pulsatility may create a favorable environment for intestinal angiodysplasias and development of AV malformations in these patients, which are actually the precursors of GI bleeding. So GI bleeding would be seen in mostly all the continuous flow LVADs. It depends, one patient might be different, and you might see an upper GI bleed or lower GI bleed. Upper GI bleed, presenting as melena, coffee ground emesis, hematemesis, lower GI bleed as hematochezia, or occult GI bleed most of the times, just hemopositive brown stool and iron deficiency anemia. Usually your treatment initially would be, conservative with medical management, transfusion if needed, because they are LVAD patients. But if you're thinking of a transplant in these patients in future, you should be very careful that you want to give them transfusions or not, because you'll be sensitizing these patients. A push enteroscopy if needed. We have also used medications like thalidomide in GI bleed patients, but the data is very, very insufficient. Sometimes you have to lower your INR thresholds, or you have to cut back on the dual antiplatelet agents. Of course, that increases the risk of thrombosis or strokes in these patients. But in HeartMate 3, it's kinder to you in terms of pump thrombosis or thromboembolic events. So you can, take these patients rather than INR of 2 to 3, you can say, 2 to 2.5 and keep them on one antiplatelet agent rather than two antiplatelet agents. Pump thrombosis, the incidence of thrombosis in all patients with VAD was initially reported to be between 2 and 4%. This is the 2008 and 2009 data, but the more recent data indicated 7 to 8% incidence of pump thrombosis by 6 months. The Intermax data actually reports an overall prevalence for HeartMate 2 of 5.5% and for HeartMate 3 about 1% incidence of pump thrombosis at 24 months. So where can actually you get the pump thrombosis? You can get it at pre-pump at the inflow cannula. You can get intra-pump, which is actually in your pump of the LVAD, and you can get post-pump, which is in your outflow graft. So these are the three places where you can get the thrombosis most of the times, and the way the parameters on the LVAD, and depending on which type of LVAD you have, those will change, and there will be different criteria for diagnosis. Anticoagulation like unfractionated heparin or direct thrombin inhibitors are used. Thrombolytics have been used, but they do increase risk of intracranial bleeds. Antiplatelets are continued. The gold standard of any pump thrombosis is pump exchange. We can put bandages on these patients with anticoagulation, but most of the time these patients are not able to get rid of those thrombus, and we end up doing pump exchanges, which is obviously difficult. And if we are not able to do it, sometimes we have done an exception for these patients and then cardiac transplantation. Thrombolysis, if not a candidate for surgical treatment, as it is associated with high risk of bleeding. Stroke in LVAD again is an important complication. So we have LVAD specific risk factors, which I already mentioned. If you have a thrombus pre-pump, post-pump, or intra-pump, if there are infections like endocarditis or a driveline exit infections, if there are traditional risk factors of hypertension, or they are, they are coagulopathic, or the INRs have been low. The early post-operative factors, if they had LVAD atrial fibrillation, air emboli, coagulopathy, infection. So these are the factors that will increase your risk of stroke in an LVAD patient. So it's extremely important to start your anticoagulation on a timely fashion and to continue to have your INRs checked regularly. So evaluation of stroke, like any other patient, guide management of anticoagulation, a head CT scan. First, you have to make sure it's not a hemorrhagic stroke, or is it ischemic? Most of the times it would be an ischemic stroke, but these patients are on warfarin, so we have to make sure there is no intracranial bleed. And they have hypertension, and that is also a risk factor for intracranial bleed. So you would make sure the hypertension, the goal blood pressure for these patients will be a Doppler pressure of 70 to 90. A CTA of the neck or the carotid, if you're thinking it's not because of the LVAD, CT of the chest and X-ray, if you want to see the device positioning, looking for kinking of cannula or device obstruction. And of course, you do this in conjunction with your neurological and neurosurgical colleagues. Aortic insufficiency is again another well-known complication after LVAD. Association of a closed aortic valve and the development of de novo aortic insufficiency during chronic LVAD support has been reported independently by many studies. And basically, mild to moderate AI will develop in approximately 25% of patients in whom the aortic valve remain closed after 1 year of support. So if you see here in figure A, there's a continuous flow LVAD and no valvular heart disease, which is the aortic valve. So you have, normal LV unloading. You have LA pressures which are fine. This is the role of LVAD. You increase the unloading. You don't have any aortic regurgitation, and the flow should be the way it is. But in a patient which has a continuous LVAD and AI, so you have flow coming from LA to LV and also from the aorta, it becomes a closed loop. So what will that cause? Decrease the antegrade blood flow in the ascending aorta. It decreases LV unloading. They increase right, left, and end diastolic filling pressures. It increases the MR. It decreases the PAPI. It increases the right ventricular afterload and lowers the decrease of myocardial oxygen consumption. And this patient will basically present with heart failure. And this is one important differential you have to think about, that is AI happening, especially in patients who have had VADs for some time. So this again, we have had a patient with LVAD where we have put a TAVR valve for treatment. So arrhythmia management in patients with LVAD, many of these patients will have ICDs, especially the ischemic cardiomyopathy patients. There are many school of thoughts if these patients should get ICDs or not if they don't have one. It depends on the centers, but the data says if you have ischemic cardiomyopathies in LVAD patients, ICDs would be beneficial, but there are other school of thoughts which don't agree with that. So if these patients have atrial arrhythmias, or if these patients have ventricular arrhythmias, what should we do? We usually give them antiarrhythmics, but VA ablation is something which can be considered as a palliative treatment in these patients. So when we do a VAD interrogation, that's a separate topic, but I think the few things which we have to think about. We look at 4 parameters in mostly all the LVADs: the pump speed, the power, the flow, which is the calculated, and the pulsatility index. So these are the 4 things which we usually look, and depending on if you have increased power or decreased flow, what are your differentials? So if you have decreased power, you have to think of a pump thrombosis. If you have increased power, you have to think of hypertension. Your afterload has increased. If the flow is decreased, you have to think about, is this patient having right heart failure, or is this patient having hypovolemia, or is this patient having suction events? So these are the few differential diagnoses. You will have mainly 2 kind of alarms. Hardware I will not be talking about because this is not even available now, but HeartMate 2 or 3, a hazard alarm, which is the flashing red heart alarm, or the advisory flashing yellow wrench or diamond alarm. Most of the time this is the most serious alarm, being red, and that will actually state to call the hospital VAD coordinator or your implanting team. And the yellow alarm is a little bit more, you can take some time to contact your team, but of course it definitely needs a follow-up. So long-term monitoring for pump malfunction, optimal device monitoring requires a systematic multimodality approach that integrates historical features, physical exam, serological evaluation, cardiac imaging, and in some instances, hemodynamic assessment. Most of these patients will get a right heart cath every 6 months just to see how their RV is. If the RV is failing, you have to kind of make changes, decrease the speed. These patients will get a ramp study to see if they are unloading well, or if you're suspicious of a thrombus in these patients. A ramp study being that you increase the speed of the LVAD and you see the size of the LVIDD on the echo. If the size decreases when you're increasing the speed, that means the LVAD is unloading appropriately. If your size remains static or it does not decrease, then you have to start thinking, is this a pump we are talking about? Of course, this will not be in isolation. You'll be doing an LDH, you'll be doing an haptoglobin, a plasma-free hemoglobin, all these features which will suggest that is there a thrombus or hemolysis. And appropriately, functional LVAD should alleviate left heart failure symptoms. So if your patient who has a LVAD which you think is functioning well and has left heart failure symptoms, you're missing something. You have to think about what you're missing. Is this patient having right heart failure? So do you have to decrease the speed, or do you have to increase the diuretics? Or is this patient having suction events? Or is this patient having hypertension or aortic regurgitation? Or is it having a thrombosis? So if a LVAD patient does not feel well, something is definitely wrong. So what will help you will be your history, physical exam, serological exam, imaging to take further steps. So here just an example of, if you can see here, this is the drive line, which is kinked here, which basically caused alarms in a patient and actually had to change the pump or body of the pump. We can leave the inflow and outflow conduits because the problem is not there, it's only the lead. So thus a minimal approach or a subcostal approach in these patients or a limited sternotomy can be done. So this will be important to determine when you're actually seeing this patient. So thus imaging is important. This is a thrombotic obstruction with an outflow graft, which can be treated with percutaneous endovascular stenting if you see this on a CT scan. Coming to pump-related infections, which is again a big important topic in complications. Pump-related infections usually are divided between three kinds, either VAD-specific, which is related to the parts of the VAD, either the power cord, pump pocket, internal surfaces, VAD-related but not directly involving the VAD, but possibly occurring as a result of VAD placement, which would include mediastinitis or bloodstream infections, and VAD non-related, which could be anything like pneumonia, UTIs, etc. So if you can see this picture, I hope it is clear. So this shows erythema with involvement of superficial aspect of skin without any purulent drainage. Usually this would require a dressing which is done every day, aseptic dressing done which is every day by your home care person or your VAD coordinator. A superficial infection which is cellulitis which might need some antibiotics. And this is a deep tissue infection requiring surgical debridement. Which actually is a problem, and sometimes we have to exchange the whole driveline and the pump body part because otherwise you can't get rid of the infection. So coming here about evolving management approaches in LVAD, implantation, outcomes and management. Surgical approaches are getting more non-invasive or minimally invasive like thoracotomy based implantation. Stroke with HeartMate 3 have reduced. There are trials being done with less intensive antithrombotic therapy. RV failure, assessment of RV failure and evaluation of pulmonary vasodilators preoperatively to reduce the RV failure. If there is aortic regurgitation, you have TAVR as an option. Infection, there is a development of fully internalized devices which could reduce the infections in LVAD patients. Myocardial recovery, again, is very important. Many of these patients, if they are on guideline-directed medical therapies with LVAD and they are the medications on protocol as per many recovery protocols exist in the world, these patients actually have LVAD explanted and done well. And many I personally have at least 3 or 4 patients who actually had an LVAD and that was explanted after 2 years and they are doing well. So myocardial recovery again is a very, very important area in LVAD research. Shared making decision again is obviously very important in implantation. So these are the few things which are evolving in LVAD implanting strategies, outcomes, and management. So again, as compared to transplant, what are the survival of LVAD? Heart transplant usually is 82% survival after 2 years of heart transplantation, and HeartMate 3 is about 79%. And there's recent data which says that HeartMate 3 is actually more than the heart transplant by a 1% or something. So at this point, because of the technology, LVAD and heart transplant outcomes have been, equal. So this is on the left is one of our pediatric patient who got implanted, I think 3 years ago, and it is a Jarvik LVAD. The driveline is here, and that's why he can swim. Otherwise, the LVAD patients who have an abdominal driveline cannot swim. And this is one of a combined heart-lung transplant who was really, really sick, who came in, ISIN mangarization, and this patient almost required ECMO, but thankfully we got an organ on the same night when the patient got really, really sick and is doing rehabilitation in our physical rehab unit. So take-home messages, evaluation for advanced heart failure therapies. I think early is the key. If we can follow this algorithm, if transplant or VAD is indicated, you take help of clinical assessment, imaging, right heart catheterization, consider all alternative therapies and interventions before listing or LVAD implantation. If the patient has low output syndrome, is the transplant or LVAD not contraindicated? Are they eligible for transfer LVAD after evaluation? If not, if they have comorbidities, then you have to think about, of course, inotropes and palliative therapy. This is a nice acronym I think all of us are probably familiar with. I need help. Patient who's on inotropes, NYHA classification 3 or 4, persistently high NT-proBNPs, end organ dysfunction, EF which is less than 20%, defibrillator shocks, appropriate or inappropriate, hospitalizations which is more than 1 actually in the last 12 months, escalating diuretics or persisting edema, low blood pressure with systolic of less than 90 or 100, inability to up-titrate medications, and you have to actually de-escalate medications. So I need help for these patients. So consider these patients as advanced heart failure therapies and consider referring them for the same. Again, LVAD can be as a destination therapy, bridge to transplant or bridge to recovery, which can provide a good quality of life in these patients, but these patients have to be selected very, very carefully. Of course, all patients cannot have LVAD or a heart transplant, so this requires a lot of meticulous evaluation and workup in them. So again, going back to the question, which of the following patients is the best choice for immediate referral for advanced therapies? And answer I'm sure you know is the last patient who has low EF, hypotensive, recently taken off beta blocker and symptomatic on minimal exertion. Thank you.
Yeah, extraordinary talk, Dr. Sonali. I think if anyone has any comments, Dr. Sukesh, Dr. Naresh, our experience with LVAD is 0, so I think may not be appropriate to ask anything. Yeah, Naresh.
Just a experience. I assisted one case with where we did in Yashoda Malakpet. One patient was a retroviral positive patient who required a LVAD. So we implanted HeartMate 3 and is doing fine. And complications out of it.
Yeah, thank you, Dr. Sonali, for your wonderful talk on advanced heart failure therapy. I think in India that the cardiac transplantation it's slowly picking up, but the LVAD this durable assist device are still being done in very rarely in few centers only. So as Dr. Naresh pointed out, it's being done in very few centers. Probably in your center you may have some experience. And probably the reason for this is also because lies with the cardiologists also. I think that we don't encourage them to go to a advanced, this center where they do these procedures. And that's the reason. And of course, the cost concerns are always there in India.
think absolutely cost is a big predicament in LVAD therapy, and you're right that transplant still it's picking up, but I think worldwide I think LVAD is picking up because there are so many heart failure patients and the donor hearts are not available, that probably we haven't come to that stage as yet because our numbers of transplant are probably not that high, but I think we will see that in future. And I think every new technology is expensive initially, and as you're using it more and more, the costs do come down, or we get it I mean, TAVR, how many patients were getting TAVR a few years ago? The numbers are picking up. How many patients were getting ablation? So I think it's the same. It will take time, but I think it will benefit patients who are not eligible for transplant, because transplant itself has so many issues. I mean, the immunology workup which we done, the panel reactive antibodies which we do, I think we underestimate the risk of rejections when we do this immunology workup. So I feel many of these patients undergo a lot of rejections, the younger patients especially, and the compliance of these patients with immunosuppressants, especially the younger patients, is not that much. And many of these patients, that's why, can benefit from LVAD. And many of the patients with comorbidities, most of the patients which we are seeing with heart failure are not your straightforward 50-year-olds who do not have any other comorbidities. There are so many patients who will be diabetic, have renal insufficiency. I think these patients can benefit from LVAD therapy. Of course, cost is a constraint, and I think time will tell us what that leads to.
Yeah, technically it's not difficult to do this procedure. Like I was involved in implantation of HeartMate. The first HeartMate, we used to put it in the preperitoneal region and all the stuff. And I was in Cleveland Clinic. The problem in India, more than the cost and other things, is someone has to take care of. Like surgeon cannot do all those things.
Right.
Here, the problem is, you listed so many complications, and so many parameters to see for thrombosis and those kind of things,
Right.
like surgeon will be busy in so many other things, you will not be able to take care of it.
Absolutely.
The reason why the numbers have not increased, because we don't have adequate number of cardiologists, who are trained to do
Right.
these things, they're not available.
Right. I think, sir, heart failure right now is at that stage where maybe EP was 10 years ago. We didn't have a lot of electrophysiologists. Right now, I think heart failure is starting. Still, everyone thinks, heart failure can be done. The issue is that I think heart failure has so many chronic things that they've actually become like a primary practitioner for these patients. So I think the follow-ups are really important, because many of these centers are doing 2 transplants, 3 transplants, and there's no one to follow up, and these patients don't do well. So I think till we have a downstream good way to support these patients, this will not be a success. And I think it will be a success if there's a follow-up and patients will tell each other, we are doing well. There'll be more success stories to share. There'll be patients who will actually do well. I mean, our patients have gone back to work. They have done well. And I don't say this is for everyone. I think there's only 1% of heart failure population which actually requires advanced therapies. Most of the patients should still get medical therapy. We should exhaust all our options. But I think to follow them up very closely, seeing them every 6 months or seeing them every 4 months might not be enough. You have to see these patients more frequently. If you've exhausted everything, then you think about the advanced therapies. But I mean, I think we have to convince everyone these therapies work and they have a good outcome and good quality of life, because the immunosuppressants after the introduction of tacrolimus has changed the arena of immunosuppressant, of transplantation. And now we can actually manage these patients only with 2 immunosuppressants. They not even have to be on steroids. I'm not talking about lung transplant. I'm talking about heart transplant. After 6 months, if your patients are doing well, they will be basically on 2 low-dose immunosuppressants and no prophylactic anti-infective medications. So basically, after 1 year, you are on 3 or 4 medications, which are life-saving. But I think it's like heart failure having 5 medications or 4 medications whose prolong survival.
Add on to what I said, like few years back, I went to New York to see, just to see and learn about LVADs and all the stuff. Now, transplantation is a part of observership. And after the surgeon finished the operation, I asked him, what are the immunosuppressive protocol you use? And he said, I don't know. Just talk to the transplant cardiologist. So here also, we also should develop, transplant, like a heart failure cardiologist who can take care of all that.
Right,
so.
right. No, definitely they need a very close follow-up.
I think.
Actually, the insurance, the cost constraints, insurance don't pay for the latest procedures. They only give 50% or even less. What if we could find in the earlier, like before the patient is setting up into heart failure, we'll start with GDMT, and then we recognize in a later stage they made progress to advanced heart failure. What if we can advise our patients for the next coming insurance term, better go for the latest plan. Now Star is offering Star Azure, which will ensure full guarantee of even the latest procedures, and it has come up with heart related specific insurance plans.
Right.
I think these would be better, and especially if a heart failure is a gradual process, we identify them in the earlier stage, tell them next year or so later, you may develop into a advanced, and at that time it would be better if you migrate to a better plan. You would definitely require that.
Right. No, I think you're bringing a good point. So I think that's what an advanced heart failure center team does. I think we have to get away from the thought that once we send the patient there, the patient is not going to go back to a primary cardiologist. We will definitely send the patients back. It's your patient. We will do everything with a co-shared management. The point is that we tell them about few things they can actually be ready for. Because this is not something which will happen overnight. They have to prepare, arrange funds, as you said, let them meet a financial counselor, let them actually participate in the decision. Unfortunately, what's happening is once these patients either crash and they just get on Iabp or ECMO, their outcomes after transplantation or VAD will not be good, and then we are blaming the therapies for that. So I don't think we can blame the therapies for that. I think we have to see these patients earlier. And, just meeting with them, having a discussion with the family and the patient will go a long way, because so many patients come and we say, I think you're okay right now. You are walking about 300 meters on a 6-minute walk test. Come back in 6 months. Follow up with your primary cardiologist, come back. The next time if the 6-minute walk test is 275, you think of something, or you do a CPET, which is borderline, you think of, something. So I think it's a whole, I think we have to accept the therapies first. We have to accept the therapies and give them a chance, and at least take the patient and let the patient decide. I mean, I think it's their right to decide, to know that these therapies exist. And I don't think in 2022 we can be paternalistic saying that this is not good for my patient or this is good for my patient. I think we give them, we tell them the pros and cons, and then let them decide what would they want and what sort of quality of life they want. Some patients have told me, I can never think of a transplant. I'm 56, I'm happy the way I've lived, it's okay. If I die, I die, which is fine, which is great. At least they are clear about it. But there are some patients at 65, they want to live another 10 years. So I think it has to be tailored as per what your patient needs. I mean, if there are obvious contraindications, obviously, you would not push them towards that. But if we think that there is a small chance that we can provide them with a good quality or better quality of life than their existing life, which is hospitalization every few days, I think it's a good therapy to think about and talk about and learn about.
Any further questions? There are none. I think I would like to thank Sonali. That was a wonderful lecture. Thank you so much. Very exhaustive.
Thank you. Thank you, everyone.
Wonderful.
Thank you so much.
Thank you so much, Sonali.
Thank you so
So
much.
we'll close here. We are over.
It's like a family session now.
So I'd like to thank all the chairpersons, Dr. Somraju, Dr. Narasimhan, Dr. Rajiv, Dr. Prasad, Dr. Mukesh, and all the analysts and speakers. I think we've had a good talk, but we're well over time. There's dinner, and there's also the module that anyone interested can take a look at. Thank you for the good session.
Thank you.